It is live. Sanjay sir, it is live. Please start, sir. It is already live.
Sanjay, start.
Okay. Very good evening to all of you. Greetings from Chandigarh, India. It is my pleasure to welcome all national and international faculty and speakers, as well as the august audience on behalf of Department of Endocrinology, PGI MER Chandigarh and Endocrine Society of India for this International Pituitary Conclave 2021 at Chandigarh. This conclave is for 2 days, and today and tomorrow from 7 p.m. to 10 p.m. We wish to meet you all in person, but due to this trying situation, we are meeting on the virtual platform, and you can say this is kind of a hybrid meeting. Few people are personally and others are on virtual ground. Knowledge in the field of pituitary is increasing, and especially increased much more in last 2 decades. And this conclave is organized to disseminate the knowledge about the pituitary disorders among the young endocrinologists as well as the senior endocrinologists. And to abreast with this knowledge in the field of pituitary disorders, this conclave is organized. In this welcome address, I would like to personally welcome Dr. Paramjit Singh. He is Professor of Radiodiagnosis, PGI MER Chandigarh. Professor Marta. Indeed, Dr. Marta is part of our department, or we can say the adjunct faculty of our department. She visited many times and we are collaborating with her on the various aspects. Professor Lou Methril and Professor Solo Melmed, Professor Herman Muller, Professor Amar Al-Agha, and Professor Maria. In addition to that, it is my pleasure to invite my faculty colleagues and the seniors from the department, Professor R.J. Dash, Professor R. Muralidharan, Professor Anil Bhansali, Dr. Niranjan Khandelwal, and as well as Professor Nikhil Tandon, Dr. Nalini Shah, Dr. Ish Bhatia, and Professor Subhankar Chaudhary. So as we know that knowledge is one thing which sharing it increases. And I'll end my welcome address by saying few lines is that सरस्वती के भंडार की बड़ी है अपूर्व बात, जो खर्चे त्यों बढ़े, बिन खर्चे गर्ज जात. So that means that knowledge is sharing, with discussion it increases. And I'll request or urge all our participants that take the opportunity to learn from the stalwart speaker on the pituitary disorders in next 2 days. And I end my presentation. I am handing over mic to the organizers for the subsequent proceedings. Thank you very much.
So now I would request Professor Niranjan Khandelwal and Dr. Chirag Ahuja to introduce Sir Paramjit Singh for the first lecture.
Am I visible? Yeah. Good evening, everyone. Excellent day to start, in the sense that Dr. Paramjit is a man who actually worked his neuroradiology mostly in the endocrinology related area, especially the pituitary. Dr. Paramjit and myself worked together for a considerable period of time at PGI. He is currently the professor in Department of Radiology and convener or neuroradiology section. He is currently the president of Indian Radiology and Imaging Association Chandigarh, Chandigarh chapter. He has been awarded as a fellowship of Indian College of Radiology in 2020. He's been past president and visiting professor to various institute and universities in India and abroad. And Chirag, you want to say something now? He's a good colleague, and let Chirag introduce him, because Chirag is currently working with Professor Paramjit.
Thank you, sir.
Yes, Chirag.
Thank you, sir. It's indeed a privilege to be amongst, actually, both of them are my teachers, Dr. Khandelwal, Dr. Paramjit. Both have actually nurtured me right from when I actually joined my residency. So without much further ado, so he's heading the department, the division of neuroradiology at PGI. He's an avid neuroradiologist, has multiple other hobbies as well, sports enthusiast as well. So we'll just, I think, we'll start off with the lecture. And the topic for today is hypothalamo-pituitary lesions, a visual treasure. So I'll invite Dr. Paramjit Singh to take over.
Paramjit, please.
Sir, unmute.
Unmute, Paramjit.
And warm welcome and my greetings to all the ladies and gentlemen who are going to be participating in this conference. And it's a privilege to be invited for this lecture, and I thank the organizers for that. And I will be speaking on cellular and hypothalamic pathology, the visual treasure. I will show some examples, some interesting images, which will make us wiser. And now, the key to radiological interpretation of pathology lies in this area, lies through the knowledge of a complex anatomy of this area. And as we know that that's our sagittal view, the most beloved view of the cell, cannot be better than this. And here we see that the pituitary gland is lying in a saddle-shaped cella tursika, and it has got anterior lobe as posterior lobe, which is brighter because of the neurohypophysis. There is a stalk connecting it to the hypothalamus, and the optic chiasma, which is lying at 45-degree angle, approximately 4 to 5 millimeter above the tuberculum cella. Behind, we can see that midbrain, mammillary body, pons, and medulla oblongata. And the hypothalamus actually is a structure which lines the side walls and below the third ventricle. And in a midline section, it is not visible, but one can approximately say that from anterior commissure, this white fiber bundle, to posterior commissure, that's the boundary of the hypothalamus. Yeah, sorry, my pointer was not on. So now you can see. So laterally, the cella is bounded by two vascular venous structures contained within the dural reflections, an outer dura and an inner dura. It contains that's the boundary of the hypothalamus. Yeah. So the height of pituitary gland is quite variable, and there are a lot of physiological events which happen. So laterally, the cella is bounded by two vascular structures contained within the dural. Okay, so a general rule is it can vary anything from 6 millimeters to 12 millimeters. In late pregnancy and postpartum period, it can reach up to 12 millimeters and can show a superiorly convex margin also, but that is nothing to be alarmed about. That is physiological. And that's the coronal view, which shows the cavernous sinuses, venous sinus containing structure lying within a split dura, inner and outer layers of dura. And the inner layer reflects over the cella, the pituitary gland, to form the diaphragma celli, through which the infundibulum passes. Now that's the anatomical graphical representation of cavernous sinus, and one can see On lateral wall of the cavernous sinus, one can see the third nerve, fourth nerve, ophthalmic division of the fifth, and sometimes you can also see the maxillary division. The sixth nerve, abducens, lies within the cavernous sinus, just on the side of the carotid. The carotid forms a sulcus. The intracavernous part and supracavernous part is seen, and that forms a C-shaped sulcus lying on the lateral aspect of the sella turcica. Below is the sphenoid sinus. Now, these structures can be well shown on some high-resolution studies which the current MR scanners provide, something like a Swiss image or a space, which is a 3D 1 millimeter sections. But however, in this section, one can still make out those nerves and the empty space, venous space, the sella infundibulum, and the optic chiasma here. So, to decode this area, the pathology, we have to first of all identify the pituitary gland, sella turcica, and then determine the epicenter of the lesion. Where is the center of the lesion lies? It is above, below, or lateral to the sella. Then the character of the lesion is to be decided on basis of what kind of signal it shows on MR, whether it is cystic, solid, there are flow voids in it, or calcifications, and then we tend to try to reach a differential diagnosis. Now, that is history. We used to do this a lot in old days, and this is the lateral view of sella, and one can see the bony anatomy so well shown, and we used to look for very subtle signs of something lying there, dorsum sella, anterior clinoid process, and the floor of the sella formed by a pencil-thin sharp line, lamina dura, and sphenoid sinus lighting below. And if we look at this, we used to also try to gauge the size of the sella on plain X-rays. But overall, we had a few clues to the pathology. The upper one can see the outline of sella. It is hollowed out, but the dorsum is still maintained. And this is a closed sella. It indicates a tumor which is lying within the pituitary gland. On the other hand, in this example, we see the dorsum is completely gone and sella is widened, and actually the outline of boundary is not seen at all. This is open sella. This usually indicates a lesion is coming from above and destroying the cellular boundary, the bony boundary of the sella. Now, speaking in an endocrine specialist conference and talking about adenoma will be a little too much for me, but then still then, just for basics, they're the commonest brain tumors, in fact, 17%, and they arise from the adenohypophysis, and they're slow-growing tumors. Overall, non-functioning tumors are around 20% and functional are 75%, and these are the different origins, the commonest being lactotroph-related prolactin secreting tumors, followed by corticotrophs and somatotrophs, that is growth hormone. And these are the syndromes it causes. Then we have thyrotrophs, gonadotrophs, etc. And imaging has revolutionized the detection of these adenomas, particularly after invention of MRI and before that CT scan. And we used to have a sensitivity of around 70% on CT scan, which went up to 70 to 80% after introduction of MR. And then we started using contrast, 10% sensitivity went up, and the dynamics CMRI, which added another 20%, and then the delayed scans for some occult lesions after 30 to 60 minutes. So these were the advancements which happened, in fact, 2 decades back. So that's how adenoma looks. Now, adenoma can cause shift of stalk to one side, cause upward bulge of the gland outline, downward bulge of the floor. It will usually be seen on T1 as a slightly hypointense area within the gland, and it may be iso slightly bright on T2 here, and CT will show it as a non-contrast filling lesion here, as seen in this. Now, that is a T1 weighted non-contrast image, and on this contrast image, we can see that how the adenoma stands out against the enhancing pituitary tissue. Pituitary tissue is one of the most avidly vascular structures, and it really takes up contrast. On the other hand, sometimes on T1 weighted images, the adenoma may appear bright. This could be because of past bleed, or it could be because of proteinaceous contents. And in such situation, if you give contrast, it may actually disappear, like in this example. So we have to understand what actually is the contrast dynamics, kinetics of the pituitary gland and the microadenoma to bring out these lesions. Now, if you look at these two curves, the normal gland enhances quite rapidly in first 60 to 80 seconds. And at around 80 seconds, it becomes contrast is maximum between the two.
After that, the stellar washout starts and adenoma keeps on accumulating contrast, and after some time of say 100 seconds or so, they start becoming isointense. By 2 to 4 minutes, it should be actually crossing over, and adenoma may start appearing little more bright compared to the gland, because the gland is washing out while the adenoma is still accumulating contrast. So he can see here plain MRI showing the lesion, of course, here, but if we give contrast, one can see that the portal hypophyseal system is giving this tuft of contrast in the superior surface of the pituitary, which spreads out into the rest of the gland, which becomes very bright, and adenoma is most visible. This should be around 60 to 80 seconds. After that, the adenoma becomes less definable because it starts accumulating contrast and the gland is losing contrast. So that's the explanation of that curve and how we use it. Now, Cushing's. These are the most difficult adenomas. They are usually very small because they produce symptoms very early and the symptoms are quite dramatic. So Cushing's disease is one of those very, clinically evident kind of manifestations. And at that point, to treat it, we are asked whether it has got a central origin or a peripheral disease or a syndrome. And then we do our best, try to do our best to find out a ACTH secreting adenoma. And here we see a small one lying in the center, surrounded by enhancing pituitary tissue. Now, this is just seen on delayed images with a little bit of speck of contrast in the middle of it. And of course, if we don't see, then we are in trouble, and then we have to go all the way to inferior petrosal sinus samplings and so on to rule out a central lesion. Otherwise, it can be a disease, and you can find something else due to ectopic secretions coming from the mediastinum lungs or from the abdomen. Like here in the case, this is a adenocortical carcinoma. This courtesy from the book by Professor Anil Bansali. He gave me these images for my use. So without asking him, I'm using it. Thank you, sir. Now, these were small lesions. Now, small lesions which are hormonally active, they manifest early and therefore they are picked up and diagnosed early. But those who are not so much hormonally active, or maybe they are slow growing lesions, they do not produce symptoms because of hormone overproduction, but because of the mass effect it causes. And usual guideline is below 1 centimeter we call micro, and above 1 centimeter we call them macroadenoma. Now here is a macroadenoma more than 1 centimeter in size. These are isodense to the brain, isointense on T1, slightly hyperintense on T2 the brain, and they take up contrast again quite avidly. Now they are more commonly, the non-functioning pituitary tumors are macroadenomas compared to micro. So they have a tendency for their long-standing presence in the sella. They cause erosion, expansion of sella, and one can have this figure of 8 or snowman kind of appearance. It will produce mass effect on adjacent structures. You can have bitemporal hemianopia, or maybe visual acuity problems, or headaches, and generally they are lobulated. And however, this is very homogeneous, but when they are large, they tend to undergo necrosis, cystic changes, they undergo bleed sometimes, and necrosis, and so they become quite heterogeneous in such situation. Most of the lesions are T2 hyperintense, but growth hormone producing adenomas can be hypointense on T2. They all show good contrast enhancement. Now, adenomas may not present in a standard way, and there can be atypical presentations, and there can be atypical adenomas in form of so-called malignant, very rare, but yes, sometimes we encounter them. Invasive adenomas, which are largely infiltrating into surrounding structures, dura, bone, and sinuses. And then such large tumors which are metabolically very active, particularly with nowadays we are having molecular markers for invasive adenomas. We are having KI 67 and PF 63. I think I'm correct with those molecules. They tend to have a lot of proliferative index, and they can undergo hemorrhage. And then we have multiple hormone secreting adenomas, we have non-functioning adenomas, and then we have Nelson syndrome, where if you do a bilateral adrenectomy for Cushing's disease, and there is a adenoma which was not picked up in the sella, it will undergo significant enlargement in size and produce dramatic syndromes. So here is a case where you can see that the adenoma has got a cystic area within it, which is very bright. And this kind of bright signal on T1 and T2 comes from blood. This is deoxyhemoglobin. And we can see that layering of RBCs in the dependent part, which is the because of they are contained within the membranes, therefore they cause fluctuations in the magnetic field. So there is loss of signal, and they have a hypointense signal because of that susceptibility effect. But we have to remember that in very young infants, because the gland is highly proliferative and active at this stage, up to 4 to 5 months, the gland can appear very bright on T1 and appear enlarged also. One should not be alarmed with that. This is normal. Now, invasive adenomas, as we talked about, sometimes more often they will be non-functional, and therefore they will assume a very large size before they produce symptoms because of mass effect. And then we can see that they have a tendency to infiltrate the cavernous sinus. Approximately 10 to 25% invade cavernous sinuses. Some grow down into the infracellular area, supracellular, and one can see that these are so these invasive are actually locally destructive. They are not necessarily malignant, but they are locally destructive tumors which have got high proliferation index, which is molecularly confirmed by certain molecular tests. And here we see the example where the paracellular and supracellular extension of a large adenoma, microadenoma, is seen. Now, it is very important that cavernous sinus invasion should be diagnosed, because if it is not diagnosed properly, there can be surgical problems with removal of the adenoma, and suddenly the surgeon may find itself in trouble because he is trying to cut out a tumor which has invaded a highly vascular structure like cavernous sinus. So there are different classifications for this. The one which I like, or I find it easy to quote, is Knopf's classification of cavernous sinus invasion. Now here, the adenoma lies at the center, and we have 3 lines. One is the line which is joining the medial border of the carotid arteries. The other one is the center of the carotid arteries. The third one is lateral aspect of the carotid arteries. And fourth is, we'll come to that later. So if it is not reaching this medial line, then it is grade 0. If it is reaching up to the center of the artery, the line joining the center of the 2 arteries of the cavernous and intracavernous portion, then it is grade 1. And if it crosses that but does not cross the lateral line, like in this example here, then it is grade 2. Now, up to this point, we can say that probably cavernous sinus is not invaded. But once the tumor goes outside this outer line into the space lateral to it, then the chances become nearly 85% that cavernous sinus is involved. Beyond this, it is all the way cavernous sinus invasion only, where it has gone down into the compartment which is superior, and then it has gone to the compartment which is inferior, and finally it completely encircles the carotid, which is nearly 200. So if the ICI is encircled more than 67%, then it is 100% predictive of cavernous sinus invasion. And if the obliteration of carotid sulcus, venous compartment, is there around the artery laterally, then it is 95%. And lateral tangent, if the line of lateral tangent is crossed by the adenoma, then it is 85%. So therefore, these 3 categories mean they are probably dealing with cavernous sinus invasion. However, on the other hand, if the tumor is not touching less than 25% of the diameter of the artery, the circumference of the artery, and there is some pituitary tissue still lying between the adenoma and the cavernous sinus, or the tumor has not gone beyond the medial line, then this means that there is very little chance of cavernous sinus invasion. These are practical things. Now, other thing that MRI has recently started doing is talking about the soft type of adenomas versus hard adenomas, for which diffusion weighted image is used. Like in this example, which is a soft type of adenoma, which has got a diffusion restriction. What is diffusion restriction? It is the catching of the movement of the molecules within its environment. If they are moving too much, then the lesion is probably hard. And if it is not moving so much, then it is probably soft, because the interstices of the tumor holds the water. Therefore, diffusion weighted images can be done for facilitating surgical removal or anticipating what kind of firmness. Firm tumors are always difficult to excise compared to soft lesions. So once the tumor is very large, it outlives its blood supply, then at some point it may undergo tissue ischemia, followed by infarction, and that may be followed by bleed, and the patient comes with apoplexy. And this word actually means struck down with, patient struck down with epilepsy. Now, this was a case. Now, what are the factors which can cause bleed? One is the size outliving its so-called, just a minute. Yeah. So now here we see in this example that cella is closed. Therefore, the tumor must be coming from within the cella and growing up. So it worked. So these are small points which sometimes we used to use in past practice, not required now. So now this is a tumor. The CT shows density within it, that is bleed. And this necrosed blood tumor has only peripheral enhancement only, and starts appearing dark on T2. That's why these macroadenomas which have these kind of events, they become extremely heterogeneous in appearance. Now, this was a patient of ALL, B cell precursor, and he presented with third nerve palsy, as this clinical picture shows, and he had a platelets of 20,000. Now, what are the other factors which can cause what are the factors which can cause bleed in this kind of situation? Coagulopathy is one, chemotherapy is the second, again leading to abnormal blood changes, and then leukemic deposits themselves. Now, this was a case discussed in CPC, and it was a supracellular lesion. Pituitary gland was separately seen, cystic lesion, and he was probably a child, and a diagnosis of craniopharyngioma was given. The odd point was that there was too much edema around this lesion. Craniopharyngioma should not show so much edema. That was a clue. But we missed that, and we thought it is craniopharyngioma operated, and it turned out to be tubercular abscess. So tuberculosis is very common in certain parts of the world as ours, and we have to always be ready to come across this kind of surprises. Now, it is a hypothalamic glioma. Now, the commonest type, 20 to 30%, yeah, should be the opticochiasmatic thalamic hypothalamic gliomas. Now, here is a lesion in hypothalamus. It is extending into the along the optic nerve, and on the other hand, these are normally seen in neurofibromatosis 1, but on the other hand, there can be non-syndromic lesions which can again present as optic chiasma thickening, and there is diffuse infiltration of the hypothalamus, and such lesions also have a tendency to infiltrate the optic radiations and tracts. So one should see the entire brain. In fact, it is going down into the midbrain also. These are infiltrating glioma, which has gone all the way to infiltrate the brain beyond what is visible here. So this is bilateral optic pathway gliomas, pathognomic of NF1. Now, there is one special condition which we have encountered and found us to be floored by that particular. I hope it is projected. No? Huh? Okay. So there has been experience of high association of aneurysms with adenoma, and particularly growth secreting adenomas are more commonly associated, up to 12%, 15%, and the incidence goes up to 7.4 to 15%. Like in this case, we see there is a tumor which is quite heterogeneous on MR. That means there is necrosis, bleed, and so on, and it is tending to invade the cavernous sinus. Probably not very suggestive, but yes, early. Now, we did a CT angiogram, and we found that there is a aneurysm here, Now, this is a catastrophe waiting to happen. If a biopsy is done or surgery is attempted, there will be torrential bleed, and the patient is gone. So that was the incidence of primary pituitary adenoma with aneurysms up to 15%. And interestingly, the adenomas have got the highest association with aneurysm compared to any other CNS tumor if you randomly sample the tumor patients for aneurysms. And these usually are around the circle of Willis. And in one of the studies, out of 161 acromegalic patients, DSA was done in 152 and aneurysms were seen in 26 patients, 40 aneurysms in all. And GH level at the time of onset was found to be highly correlative. So what is causing aneurysms? Now, there are many theories. One of them is growth hormone itself, collagen metabolism abnormality, mechanical, hormonal, tumor vessel microcirculatory influences, direct contact with vascular infiltration, traction by adherent adenoma. Any of these factors can work. But if you are seeing adenoma, must look at the paracellular area for any kind of an aneurysm there. Now, aneurysm can be supracellular, like in this case. One good clue to aneurysm is the peripheral calcification. 2 is a central enhancing lumen, which is the patent aneurysm lumen. And around that are the concentric thrombotic events which happened in the past, giving rise to this concentric lamellar kind of appearance with a flow void of the patent aneurysm. Now, I will give you a clue here. If you look carefully in the phase encoding direction between MR brain is left to right, you will see these artifacts. These artifacts come from pulsation of the aneurysm, and one can probably see them if you change the window. And these are the lamellar thrombus around the. So this kind of picture one should keep in mind. CT shows peripheral calcification. This is another patient, and there is another aneurysm here. Now, on the other hand, I'm not covering paracellular areas, but one interesting thing which floored us in past and caused us problems in diagnosis was this kind of lesions, which appeared highly enhancing on routine contrast, and it had a pre-contrast, a medial component which was bright, but rest of it was dark, and that strongly enhanced completely in a delayed section. We thought of all kinds of things, meningiomas and so on, but it turned out to be cavernous sinus hemangioma. Now, to confirm it, we have to do a delayed study, contrast, in a sequential manner, where initially the tumor will appear hypo, followed by some filling up of the spaces within it, and on a delayed image up to even 10 to 15 minutes, you can find that it is gradually filling up, finally taking this kind of picture. So this is how we diagnose hemangiomas, and it is a diagnosis which should be kept in mind. We have come across quite a few patients in the last few years. Other thing is meningiomas are usually paracellular, commonest paracellular tumor after adenomas, of course, which are infiltrating the cavernous sinus. But here, if the meningioma lies in the midline, then we have a problem. Is it a meningioma? Is it adenoma? What it is? Now, here's a clue. You can see the gland separate from the tumor. Then you know this is not a primary pituitary tumor. Because if a pituitary tumor grows to this side, it will invariably infiltrate the entire gland and it will not be recognizable. But here, you can recognize it separately. Second thing, you can see a dural tail here, which is going along the planum sphenoidale here. The criteria is the tail should be tapering distally and becoming thicker proximally. One, it should be more bright than the tumor itself. Sella should be seen, the pituitary should be seen separately, and it should be enhancing. And of course, on meningiomas, one can see hyperostosis, one can see pneumosinus dilatans, that is dilatation of the sinuses also in meningioma. So that's how we diagnose this. Now, here is a case where we have a pineal lesion, and then we have some enhancement of the ventricular lining, and then we have another lesion here in the supracellular area. Now, this kind of combination in a lesion which is quite contrast avidly enhancing, the pineal region showing tumor showing some cystic areas within it, ependymal enhancement, one should consider germinoma, and one should do a diffusion weighted image because that will show diffusion restriction again. So germinoma, I will come to other conditions soon. So this is a germinoma pineal. The germinomas of the pineal region are predominantly males, while here is a slight female predominance. But once you see 2 or 3 of them, that means it probably is metastatic CSF metastasis has happened. So this is a tumor which causes CSF metastasis. Therefore, entire neuraxis should be imaged in these patients. Now, this is a 10-year-old child with diabetes insipidus, exophthalmos, and lytic bone lesions. Now, this is a triad which is classically associated with Langerhans cell histiocytosis. Now, this is a multifocal granulomatous pathological tissue, which is a recurrent disease and it is an aggressive disease, and it typically involves the hypothalamus and the stalk. And these are the two areas where in this patient are involved. And one can see that this is strongly enhancing. There may be absence of the pituitary bright spot in these patients, and normally they can be unifocal, where they present as lytic bone lesions, isolated lesions, or they can be multicentric. In multicentric, usually we find this kind of changes in the pituitary hypothalamic axis, and these lesions normally will have bone lesions as well. And here we see a lesion in the bone. So look beyond sometimes the sella to the surrounding structure, which may give you a clue regarding the diagnosis. This made the diagnosis, in fact. So they are very strongly enhancing, and we can see it here. And they cause diabetes insipidus because of involvement on the infundibulum. Lymphocytic hypophysitis is another autoimmune condition. Postpartum ladies or after pregnancy, younger females, and again, it can involve the anterior pituitary, posterior pituitary, or the infundibulum, and which is very classical. And imaging is non-specific, and LCH and metastasis, etc. Everything comes into differential diagnosis here. But here we will see that the involved part is thickened, enhances, and posterior pituitary bright spot is again absent. Epidermoids. Now coming to cystic appearing lesions, epidermoid is one of them, supracellular. Now, in epidermoids are generally come to differential diagnosis with dermoids. The difference between the two is dermoid is a more midline lesion, and epidermoids are more lateralized lesions. Now, epidermoids commonest place is CP angle followed by supracellular cistern, and but epidermoids are 5 times more common, and they happen in older age group. Although they are supposed to be congenital lesions, but they produce symptoms because they are very soft lesions, and they have a tendency of having infiltrating, insinuating margin. You see, it is not a well-defined margin like of adenomas or even arachnoid cyst or Rathke's cyst. This is irregularly, and the catch is it will show diffusion restriction again. This is it. Epidermoids are very strongly diffusion restricting lesions, and they will appear like a light bulb kind of sign will be produced. Now, typically, they will be nearly iso-intense on T1 and hyper-intense on T2, just like CSF, but one can use flare sequence and they will not be suppressed completely. That is another useful way of coming to it. Now, that's a Rathke's cleft cyst. As we know, it arises from the Rathke's pouch, which is a remnant connecting the oropharynx with the brain. And they usually present either a very small lesion within the pituitary gland itself without causing any displacement, or they can extend to supracellular area also. Usually they are clear without much of contents, but sometimes because of proteins and mucin, they can be dark on T2. Here it is bright on T2, which is classical, but actual suggestive for Rathke's cleft is the hypointensity on T2, or sometimes you can see a nodule within it, which is a ball of mucin with some proteins, and that is one of the classical presentations of Rathke's cleft cyst. They are usually small and they do not grow much, but then they can be followed up, but they can sometimes grow, and that is what Rathke's cleft cyst is there. Now I will come back to how much time we have? Okay, so we have come across some interesting studies in the literature, and one of them, it is from Dr. Pinati Datta himself, who is present here in the hall, and it was about extrapituitary birth defects and in a short child and their association with congenital hypopituitarism, and this was published 4 or 5 years back. And here was a boy who had bilateral strabismus, malformed ears, depressed bridge of nose, micropenis, and short 4th metatarsal. Now, this patient was MRI was done, and which showed that the pituitary gland is very, very hypoplastic, and there is a pituitary bright spot has shifted from posterior pituitary location to at the floor of the third ventricle, and that is at the so-called hypothalamus base. And one can see that there is absence of septum pellucidum, and there is also optic chiasmal thinning. So generally it was observed in this study was that this kind of extra pituitary birth defects which involve CNS, ocular and skeletal manifestations in a short child is a clue to diagnosis of congenital hypopituitarism, and a full study of the same should be endocrinologically should be done. Now 79% of patients who had these defects had multiple hormonal deficiencies, but in all of them growth hormone was universal. And then all these patients to various combinations showed midline defects, which were facial, palate, lip, hypertelorism, and as well as brain. Like in this case, there is no septum pellucidum here. So hypoplasia of the pituitary gland was observed in most of them, and there was ectopic pituitary bright spot, which we have seen in this case here. This was another case, again, child with multiple pituitary hormonal deficiencies, and he had left non-paretic strabismus. He had left temporal pallor, and there was visual path defects on the left side, which was done by electrophysiological studies and VER and other things. And again, the extra pituitary, the bright spot had shifted up, and that was EPPBS, and that is extra posterior pituitary, ectopic posterior pituitary bright spot. And the optic nerve was hypoplastic in this patient, that showed that the visual system was involved in these patients. And the third case was
is Dr. Paramjit there? I believe there's some connection error.
Is it in my system or Chirag?
No,
I think it is an error, sir.
Okay.
They're probably correcting it. Even I felt that.
Yes.
So while they're so are you there, Dr. Kandela?
There, I'm there.
So while they are correcting, I think we started getting some questions as well.
Yeah, I think Paramjit is there. Can you hear Paramjit? Chirag, why don't you shoot up the question, whatever is coming on our way?
I think, but we really need a person to answer. Param.
Where is gone?
Param sir, please unmute.
Dr. Param, unmute.
Yeah. No, it was a problem of connection actually.
The problem is in the venue where he is.
उधर अलग चल रहा है, इधर आ गया.
Carry on now.
Yeah, so we were discussing this case with persistent craniopharyngeal canal, and here we can see that there is a malformation of the diencephalic floor. The tuber cinerarium here. Okay, right. Okay, can you hear me now?
Yes, sir. Yes, sir.
Right. Okay. So we saw this, and we saw this malformation at the floor of the hypothalamus is actually convoluted structure here. The tuber cinerarium, which is generally a strip of straight line here between mammillary body and the stalk, is actually thrown into folds here. So this de-differentiation of this has not taken place, and this was one of the cases which they included in this analysis. Okay, and in this same case, we find that there was duplication of pituitary gland. Am I audible?
Yes, sir.
Okay, so in this particular scenario, we were discussing this persistent craniopharyngeal canal, which is a midline defect again, and associated with that was duplication of the pituitary gland. There was a spine, bony spine, which was separating the sella into two halves. There were two pituitary glands with two posterior bright spots, and the stalk was also two. And in addition to that, we had presence of malformation of the diencephalon, which was a thick plate of tissue, unlike normal hypothalamic floor. Yeah, right. So now, if you see the coronal images, we can see the duplication of the gland, and we can see that the carotids are very widely separated. Interestingly, it is also associated with fenestration or non-fusion of the basilar artery in the rostral part, and you can see that distally the artery has giving rise to the superior cerebellar and the posterior cerebral artery from its individual branches, not from a common trunk. Now, all these double pituitary glands with other abnormalities, which are midline generally, are called DPG or double pituitary gland plus syndrome. Now, this happens because there is a complex way the pituitary develops. The part of the oropharyngeal ectoderm and the neuroectoderm, they come together from below up and up down, and at the region of the diencephalon, they are juxtaposed, and from anterior pituitary is formed by the oropharyngeal extension, that is the Rathke's cleft, while the infundibular recess comes down and forms the posterior pituitary, that is the neurohypophysis, which is part of the hypothalamus. When this process, because of some signaling errors, undergoes disruption, then we have abnormalities which are not just one area but many areas, vascular as well as pituitary gland, as well as midline brain and face. Even cervical vertebrae splitting is also described there, and they can have associated teratomas and dermoids, as well as hamartomas of the tuber cinereum. Olfactory bulbs may be small, and there may be nasal choanal narrowing. Now, this is another patient which I took out from my archive, and there is a canal persistent with pituitary gland dipping into it. It can present in the nasopharynx as a mass, and the ENT surgeon can remove this, and patient will become hypopit. One has to be careful. And here we can see a tuber cinereum hamartoma here hanging from the tuber cinereum. And it is iso-intense on both T1 and T2 weighted images because they're part of the nasal glial, hypothalamic glial tissue. However, most of the cases of hamartoma which have been described in world literature have not shown craniopharyngeal canal. This is a very rare case that way. And this was something which I got very, very recently. There is a persistent large persistent hypopharyngeal canal, and it has got a fatty containing lesion within it, and that is a dermoid. And one can see this is on fat saturation, this is getting suppressed. This is becoming dark. It is very bright on T1. That is a dermoid. So these tumors can be associated with this anomaly. Now I will skip the craniopharyngioma, except that the children, small children have adamantinomatous lesions, and the elderly have got the second phase of the life where they get those papillary craniophryngiomas. In children, it is very easy to diagnose, but in adults, it becomes slightly difficult. Now, this case actually causes problem. We saw this as a bright, dense CT lesion, and we thought it is aneurysm, and there was no aneurysm on angiogram. And it was very dark on T2, very dark on T2. Very dark on T2. And so we thought this might be a classical Rathke's cleft cyst, which has got mucoid material or proteinaceous dense material within it. And it was actually a suprasellar lesion, just abutting along the craniopharyngeal, the path of the craniopharyngeal canal only. And it was mildly enhancing. And the diagnosis in this patient was given as Rathke's cleft cyst, but histopathology showed it was a craniopharyngioma. So craniopharyngioma of papillary type can cause problems in diagnosis. Metastasis is something which is an unusual thing in pituitary, but we have to be careful in evaluating these lesions. One can see that if metastasis is there, it will cause erosion of the sella here, like this. This is a clue. 1, 2. Metastases are short duration. They are there for short duration. Therefore, they are still supple, and therefore the diaphragm celli is not widened so much, and part of it has gone out. That is the second thing. Third thing, obviously, they will enhance. So it is not figure of 8 exactly. It is wherever available space is there, it is going and it is destroying the bone. So this is metastasis. Here again, another metastasis in a patient followed up for CA cervix, and the PET scan was showing hyper activity in this. Again, one can see the bone erosion here. This subtle bone erosion, one should raise the possibility of metastasis. Finally, we have this particular paper from Dr. Lisa, who evaluated 1,800 total patients of pituitary tumors, and out of which she found 3 cases of primary posterior pituitary tumors. And again, the lesion was more or less like a macroadenoma, uniformly enhancing, hypointense on T1, removed, and some residual was left, which was followed up for 5 years, and it remained static. It did not disappear. And this patient had 32 female with headaches and persistent galactorrhea, and her menstrual cycles were normal. Secondary hypercortisolism was there. And imaging diagnosis, of course, was macroadenoma, but it turned out to be spindle cell oncocytoma, which was TTF1 positive, which is a hallmark of all these posterior pituitary tumors, because they arise from pituicytes, and pituicytes have this particular signaling molecule. The other patient, again, who had this tumor, which was more or less suprasellar, the pituitary was separately seen, was strongly enhancing. Posterior pituitary bright spot was not there, and after operation, the patient was stable for many years, and this turned out histopathologically as our diagnosis, of course, was way too broad: pilocytic astrocytoma, pituicytoma, histiocytosis, germinoma, but it turned out to be pituitary, which was again TTF1 positive, and it was again published. So, these tumors, what can the radiologist do in these tumors? Can we diagnose it? No, it is virtually impossible. The only clue which can lead us to think about this particular diagnosis is a lesion which is supracellular, not involving the pituitary, to very strongly enhancing. Adenomas slowly enhance over a period of time, but these tumors are very rapidly enhancing. So fast imaging with contrast enhancement can probably give us a clue. And of course, absence of posterior pituitary bright spot can sometimes be observed. But yes, it is a guesswork, and I don't think we are in a position to really prospectively diagnose these, because as such, they are so rare. 3 out of 1,800 cases is too low a figure to give this diagnosis in a routine way. So thank you very much for your patience. I have just tried to show some interesting cases which are of some learning value, and we are still learning. And I'm thankful to my colleagues for giving me all this material to, reinforce my lecture. Thank you.
Thank you, Dr. Paramjit. It was really a treasure to see all these cases. There are some questions. Chirag, can you take over and ask those questions to Dr. Paramjit?
Sure, sir. So the first question is by Dr. Lisa. Is the T2 hypointensity for macroadenomas very specific for somatic tropinomas?
T2?
So basically, I think the question is whether the T2 signal character can actually distinguish the type of adenoma. And whether
well, to form a generalized opinion is difficult. It is a matter of statistics. Obviously, there is some evidence in the literature that the T2 dark lesions are more more common in growth hormone secreting tumors. So it should not be anyway specific, because adenomas of all sizes can present with all kinds of complications, and just having dark signal. But yes, I mean, there can be a clue that if it is uniformly dark, not heterogeneously dark, then probably it may be one of the clues. So we don't have exact data that statistically how significant this particular finding is, but I think we can keep a watch on that.
Right, sir. Thank you. There's another one by Dr. Saptarishi. How to approach doubtful small 2 to 3 millimeter pituitary lesions in patients with borderline elevated prolactin levels?
Well, ma'am, it is not a shame to miss small adenomas, and there can be, like, as I mentioned, that in Nelson syndrome, you try your best to rule out a pituitary primary prolactinoma, but ACTH secreting tumor, but you miss it. And later on, when he presents, the person presents with Nelson syndrome like situation with very, very rapid clinical progression and enlargement in size of adenoma, then you realize you have missed it. Yes, in our practice, we try to do our best to find the lesion by doing thinner sections, early contrast images, and high resolution 3 Tesla imaging. All these help. And then we have 3-dimensional nowadays wide sequences and MPRH, which are also good in picking up small lesions. But in spite of all this, I still philosophically remember Dr. Benjamin Felsen, who was our chest radiologist of repute. He used to say there was a lesion spot there I saw just a minute ago. Now it is not there, and here it is again. So, so these corticotrophic lesions and the small lesions can appear in different people's opinion. Yes, it is there. No, it is not there. I think it is an artifact. This is partial volume averaging. So all those technical issues are there. So to what kind of lesions you can miss also depends not only on size, but also its consistency. It may be merging with tumor pituitary background completely. So yes, we can only try. We can't be very sure that what size is the minimum. But yes, our sequences are normally having now 1 millimeter to 3 millimeter standard sequences. So that much size, if it is cut exactly in the middle of the slice, yes. But then if it is partially cut this way and that way, then again you can miss.
Right, sir. Another one from Dr. Martha. Should we screen acromegaly patients for aneurysms? And if yes, then what modality do you suggest?
Yeah, actually, incidence has been so much, and the complications of this particular missing this diagnosis have been so fearsome that there are a lot of studies where, at least one study that I quoted, 161 acromegalic patients, 152 had DSA. It was routinely done in that study, and they found 40 aneurysms. That is too much. This coming to nearly 40 to 45%.
Sorry to interrupt, Paramjit. Do you have the distribution of those aneurysms? Because if I correctly remember, we have seen some of the aneurysm associated with ACOM, maybe in the PCOM, PAR PCOM, and other areas,
Yes.
so which are not in the field of surgical field. So those, do we have that where those aneurysms are? The aneurysms which are projecting towards the sella. Those are the aneurysms which are likely to cause post-operative kind of disaster.
Yes.
But if the aneurysm is pointing in the ACOM area or in the posterior communicating or posterior, I'll say far posterior communicating, not really, or in MCA, another thing, then it will be a different. So do you have a breakup of those aneurysms?
Sir, breakup is actually not there. That's why they have seen most aneurysms probably in the anterior circulation, approximately ACOM and that area. And at the same time, there have been aneurysms which have been abutting the tumor itself. So the different theories that they have floated include hormonal, microvascular, the byproducts of the tumor in the blood, the growth hormone itself, as well as the direct mechanical stretching of the artery or tethering of the artery versus infiltration of the artery. So probably we are not very clear right now. But even if the lesion is aneurysm is deflating on the site of the tumor, then one has to be, of course, treating the aneurysm first before you do anything to the tumor. But on other aneurysms, maybe one can have two-step approach, that you can probably remove the tumor first and aneurysm later, or you can do the aneurysm. Endovascular coiling is always there. That can be done as a preoperative procedure and complete the aneurysm, completely close it, and then go ahead and do the resection of the tumor.
There is a comment from Dr. Dandapani, who said that they are screening every patient of pituitary macroadenoma with CT angio. And yes, Dandapani, can you say that?
Sir, over the last 2-3 years, we have been doing pituitary surgeries all under navigation, and we do CT angiography under navigation protocol, and so that we can identify the exact location of carotid or any anomalies. And in that, we also pick up aneurysms, and we noted that our incidence of aneurysms in these patients is not much. We hardly, in our last hundreds of cases, we have hardly found 1 or 2 patients with aneurysms. But it is different from the other literature. But somehow I thought I'll share this. Thanks.
Okay. Dr. Pathak want to comment. Dr. Ashish Pathak is there.
Yes. I just want to mention that in the invasive tumors, we have to remember that prolactinomas are very well known to be invasive. So that has to be kept in mind. At quite a few cases where it was very extensively invasive prolactinomas, especially in children, they're sort of very invasive tumors at times. And I would have been very more happy to see giant tumors that we see in our region, at least massive giant tumors, going across the 5 centimeters and things like that. The problem in these cases is that they sometimes occupy the posterior pituitary, the third ventricular area, the hypothalamus, the suprasellar cistern, everything is totally invaded by them. They're the most difficult ones. If they're prolactinomas, then the thing becomes easy. But if they're non-prolactinomas, surgery is a very difficult proposition in these. And they're invading the vascular structures, the neural structures. So those are the ones which are really nightmare for any neurosurgeon. So that we tend to see quite often, if not very often.
There was Chirag. There was one last question. Role of biopsy there.
Yes, I think the quick answer, because we'll have to wind up. The role of biopsy of the cellular paracellular lesions when the diagnosis is not clear. Any role of biopsy
Pituitary biopsy.
Role
I
of
think
biopsy.
I think I better go for excision biopsy rather than just a simple biopsy, unless you are in real doubt. And to add to my experience, I have seen 3 situations where, not myself, luckily, the neurosurgeon has gone wading into an aneurysm and then started appending without doing a proper radiological evaluation. So those mistakes have happened in the past quite often, I would say, and they're underreported also sometimes.
Thank you, Dr. Pathak. I was being stretched in neurosurgery field, which I was getting more and more uncomfortable. Thanks for taking that question.
I think it's the time we hand over our mic to Dr. Pinaki, who is the moderator, and Dr. Ganapati also. I could see him briefly. Yes, sir. Is Pinaki around? Dr.
Yes,
Ganapati,
yes.
you want to have a few comment here? Any comment on this topic?
Yes.
It's okay, sir, because it's already
Okay,
late.
all right. So then on behalf of everyone, I thank Dr. Paramjit for taking an excellent piece of treasure, shown as the excellent piece of treasure to all of us. Thank you very much.
Yes.
Good
Thank
night.
you very much, sir. So now I would request Dr. R. Muralidharan and Professor Nikhil Tandon to chair the next session by Professor Mata Corbonets. So I would hand over the mic to them. So we are already running late.
Thank you, Dr. Pinaki.
Yes.
It's a pleasure to introduce Professor Mata, who is a professor of endocrinology and metabolism at Barts in London School of Medicine and Dentistry. And her interest is on endocrine tumorigenesis, and it's appropriate that she is going to talk on a very important topic today on tumor microenvironment with relevance to pituitary tumors. Dr. Nikhil, you would like to add something?
No, I think in the interest of time, we'd request Professor Corbonets to perhaps start with her presentation.
We're very keen to listen to you, Professor Mata, on this very fascinating topic, which may have a lot of practical implications. Over to Professor Mata.
Good afternoon. Thank you so much for the opportunity to talk to you about my work, or well, not my colleagues' work on the tumor microenvironment. So as opposed to the previous talk, which was a wonderful, clinically very relevant talk, this will be a lot more theoretical and more on the research side. So the tumor microenvironment was first suggested by Stephen Paget to be important, and he founded the seed and soil hypothesis, suggesting that the TME, the tumor microenvironment, is important for metastases, but not just for the metastases, but the original site of the tumor is also important. And this tumor microenvironment is represented by non-tumoral cells, such as the immune cells, the vascular cells, and the fibroblast. And today in this talk, I would like to talk about these different type of elements of the tumor microenvironment, and then also link them to a specific group of tumors which I'm specifically interested in, which is tumors related to the AIP gene, and also will mention some therapeutic options which have arisen in the last few years. So if we start with the immune cells, in this study we had a set of samples, pituitary neuroendocrine tumors or pituitary adenomas and normal pituitaries. We compared them for the various infiltrating cells, and we looked at macrophages. We stained for CD68, CD8 cells, CD4 cells, B cells, neutrophils, and FOXP positive cells, which can also be called Treg cells. And you can see that the most numerous number of cells were actually the macrophages. And when you look into the macrophages a little bit more, you can see that you can divide macrophages in two groups, and this is rather crude division because macrophages are actually can move between these stages. But the M2 macrophages can be stained by a stain called CD163, while the M1 macrophages we stained with HLA-DR. And if you look at the macrophages within the pituitary tumors, you see that you have more M2 macrophages compared to the normal pituitary, and more or less similar number of M1 type macrophages. So if we express the ratio of M2 to M1 ratio, we see a significant difference between pituitary tumors and normal pituitary. And this is not unique to the pituitary. This similar picture has been seen in different type of tumors. And this data was also seen by the group in Lyon, who looked at CD68 in various type of pituitary tumors. And here you see with a blue staining in that data of the macrophages. And what they found, especially when they compared somatotroph adenomas and gonadotroph adenomas, probably most of them were actually non-functioning clinically, they found that the ones with more macrophages were more invasive, and especially the ones with the M2 macrophages, where this was correlating with tumor invasiveness. We also looked at this data on the RNA level, and we looked at the gene signature based on immunohistochemistry. And here you see our data on immunohistochemistry, and this was actually in a different set of samples. So we recreated the data in a different set. And then we also looked at with gene signature based analysis from a study using a deconvolution analysis. And again, we were able to find this data. Again, similar data has been found by other group. This group from the USA found that tumors which are not invading or invading the cavernous sinus have different amount of M2 M1 ratio. So the invasive tumors had a higher M2 M1 ratio, while the non-invasive tumors had a low M2 M1 ratio. So it looks that from different groups, these data is now repeatedly shown to be the case. And I talked about M2 and M1 macrophage ratios, but actually these ratios are now very popular in different type of cancers, and they look at ratios of different cell types. So for example, CD4, CD8 ratios, or CD8 and Treg ratios, or macrophage ratios with various things in different type of tumors, as you see from these papers. So taking all our data together with the different cell type, we found a signature which is like an aggressive tumor signature. If you take the ones which have a lot of macrophages, so CD68 high, also a lot of CD4, a lot of Tregs, and a lot of CD20. Then if you look at these tumors and you look at the Ki67, you see that typically the ones which were positive for all this have a high Ki67, while only 3 out of 20 who were low for these had a high Ki67, suggesting that this is actually predicts somehow the tumor behavior. So another element of the tumor microenvironment are the cytokines, and we did a cytokine array with different cytokines, and these are the cytokines we found in kind of measurable level in pituitary tumors. We used non-functioning tumors and somatotropinomas. Of course, we don't have good control from normal pituitary, as we don't have fresh normal pituitary, and this had to be done from a fresh primary culture. And if we look at the cytokines, what we saw, these are the main ones in kind of order of the amount we were able to detect in these cultures. And interestingly, the top cytokines are actually all chemokines, and chemokines are a subgroup of cytokines specialized in immune cell recruitment and chemotaxis. And just to show you that, again, other people found similar data. This is a paper based on RNA-seq study published in 2020 by another group, and they found association between chemokines and inflammatory-related genes in again, looking at B cells. You can get CD8 cells and T cells, and they show this data in their paper. Then another group of cells which are important in the tumor environment is the vascular cells, and we looked at microvessel density in pituitary tumors compared to normal pituitary, and we found that there was a lower level of microvessel density in the pituitary tumors. And we also looked at the size of the vasculature and their diameter and their areas and their roundness, so all sorts of different variables to compare that how we look at these different types of data and whether we can correlate them with the tumor aggressivity. And this is just to show that, for example, the CD163, which is the M2 macrophages, they may promote angiogenesis, as we found a positive correlation between these parameters in our pituitary tumors. And then another group of cells are the fibroblasts, and these would be the tumor-associated fibroblast in the pituitary, here staining with vimentin or alpha SMA in the pituitary tumors. And what we did, we actually tried to isolate these tumor-associated fibroblasts from the primary culture. So these are not the tumor cells, not the ones which make the hormones, but these are the fibroblasts growing out of a primary culture. And here you can see them stained. And we measured the supernatant from these pituitary tumor-associated fibroblasts, and we found that the IL-6, which is one of the important cytokines release from the tumor cells, was higher from the invasive tumors than the ones which were non-invasive. And I don't have time to tell you about the myriad of effects of IL-6 in the various aspects of tumor biology, but it certainly seems that this might be relevant for the behavior of the tumor. And then we did some studies using these tumor-associated fibroblasts. So we try to see that the tumor-associated fibroblast, could they change the behavior of pituitary cells? And for the cells, we use GH3 cells, which is a rat pituitary cell line. And what we did, we put the GH3 cells into a chamber, and underneath the chamber, we put the supernatant from the human tumor-associated fibroblast. And then we looked at how much these tumor cells can actually migrate in response to this supernatant. As you can see that compared to if we put the medium, if we could condition medium for ordinary skin fibroblast, or if we did the tumor-associated fibroblast, we saw that there is an increase of migration of these GH3 cells. And then we did an extremely similar assay, but we had a matrigel coating on the well, and then we saw how much the cells can actually invade through this matrigel. And again, we found that the medium and the skin fibroblast media wasn't really changing this migration. However, the tumor-associated fibroblast conditioned media changed the behavior in terms of invasion of the GH3 cells. And then we wanted to look at also the somatostatin pathway in these tumor-associated fibroblasts, and doing some gene expression for the 5 different types of somatostatin receptors. We found that primarily the SSTR1 receptor, which is expressed in these fibroblasts, and we treated the fibroblast with a compound which can stimulate these somatostatin type 1 receptors, and that was pasireotide. And we found that measuring IL-6 in the supernatant of these fibroblasts, we were able to reduce the expression of IL-6 using pasireotide. So another element which we looked at, and these data was done actually by my PhD student, who by the time moved on to work in Leiden, that he looked at the serum parameters in patients with pituitary adenoma. And here you can see that he looked very simple measurements, such as the platelet count of the patient before surgery, the white cell count, the neutrophil count, the monocyte count. And then he took some ratios, the neutrophil to lymphocyte ratio, and also a parameter called systemic immune inflammation index, which is practically the platelet number multiplied by the neutrophil lymphocyte ratio. And this is the data, what they looked at. So they looked at the prognostic scores of these different parameters, these ones, and also including the platelet count. And what he found that these parameters were typically present in patients who had pituitary tumors, but not Cushing. And then this was typical in Cushing patients. This was typical in growth hormone prolactin or TSH secreting adenoma patients. And these were present in non-functioning pituitary adenoma patients. So interestingly, even from the blood test before surgery, you can have some correlation with the data in regarding the pituitary tumor. So I mentioned I would like to talk to you briefly about the role of AIP in the tumor microenvironment. And we started our studies again with human samples. So here we compared normal pituitary macrophage content with AIP mutation positive somatotroph adenomas and sporadic somatotroph adenomas. And we found that there was a lot more in the AIP tumors. And we also have a mouse model for this disease, so where we knocked out the AIP specifically in the pituitary gland using HESX1-CRE model, and looking at the tumors which are arising in this animal model compared to their wild-type littermate. We found that, of course, the reticulin is disrupted because there is some tumor there, and we found a lot more staining for the macrophage-specific stain for the rat, which is this stain. So we looked at the effect of immune cells on the tumor, and we used for these studies the GH3 cell line, where we knocked down the AIP gene in these cells. So we're comparing GH3 cells with a non-targeting control, and then this is the GH3 cells which have a lower level of AIP, and here I show you the PCR, the Western blotting data on the AIP knockdown. And for the macrophages, we actually used fresh macrophages, so prepared from rat bone marrow, and we stimulated them with, differentiated them with GM-CSF and activated them with PMA. And we then took the media from these freshly prepared and freshly differentiated activated macrophages and put them on top of the GH3 cells, either the non-targeting GH3 cells or the AIP knockdown GH3 cells. And when we treated the cells with this macrophage conditioned media, you can see that the cells change their shape. And we saw this shape change both in the non-targeting cells as well as in the knockdown cells. And when we washed away the macrophage media and just replaced it again with the normal media, we saw that these morphological changes went back. And these changes are very similar, what we call epithelial mesenchymal transition. And then when you see the opposite going back to the previous stage, that's mesenchymal epithelial transition. And we quantify these changes using image J, and on these graphs you can see in the green color the non-targeting GH3 cells, and the blue color is the AIP knockdown cells. And what you can see that the middle bars are the ones which were treated with macrophage media, that you have a significant change in the GH3 cells. And in these two parameters, you have change also in the non-targeting cells, but change is significantly higher within the GH3 cells. So we looked at the area, the perimeter, and the ferret's diameter of these cells, suggesting that AIP cells behave differently. AIP knockdown cells, even in a cell culture situation, behave differently in response to the fibroblast media. We also looked at, for example, the migration of these cells, and we can see that there is more migration in response to this treatment. And we also looked at the invasion, again, the technique I showed you earlier, going through the matrigel, and we can see that the macrophage containing media stimulated the invasion of these cells more significantly, although there was a nice effect also on the non-targeting cells. But what if we turn the question around and we look at the effect of the tumor cell on the immune cells? So what we did here, we actually cultured the AIP knockdown cells, and we took the conditioned media from these tumor cells, and apply them for the macrophages, the ones which we generated from the animals. And we looked at how these macrophages behave. And what we found that when we compared the migration of the macrophage cells in response to media from the non-targeting GH3 cells as opposed to the AIP knockdown GH3 cells, we see that the macrophages are actually moving more rapidly in response to the AIP knockdown media from the GH3 cells. And we measured one of the cytokines called CCL5. This is a tumor-derived cytokine. And we found that actually, even in our human samples, we had a higher level of this CCL5s in the tumors. And we also looked at a protein which regulates CCL5, which is called FLE1. And you see that we have a lot more FLE1 in the AIP positive cells compared to the sporadic growth hormone adenomas. And when we looked at the CCL5 release with an ELISA from our AIP knockdown cells, again, compared to the non-targeting cells, we see that there is more CCL5 coming out of these cells. So the human data, which I show you here, and the experimental data from the rat cells are really nicely parallel each other. And then we try to do something regarding treatment, and there is a protein called maraviroc, which is an inhibitor of the CCL5 receptor. And when we treated the cells with maraviroc, we found that there is an inhibition of the invasion of these cells. So macrophage migration towards tumor conditioned media is reduced by the CCR5 inhibitor maraviroc. So our hypothesis is that AIP mutation maybe causes a change in the microenvironment, and that may play a role in the tumor genesis, or at least in the behavior of these tumors, which sometimes are significantly more aggressive than ordinary pituitary adenomas. And we actually have data not just on the cytokines which I showed you earlier, but even on another cytokine called CX3CL1, again with some difference between the non-targeting the AIP knockdown cells. And interestingly, similar data was seen by another group where they knocked down AIP again with an siRNA, or they put in some AIP mutants into the cells, and they looked at IL-6 concentration changes, and they found that the IL-6 was higher in the AIP cells, AIP knockdown cells, or the mutant cells compared to both in this cell type, but also in the GH3 cells. So their data really nicely parallels our data regarding the role of AIP and the immune environment in these cells. So what therapeutic options we can find in the kind of maze of immune systems? And that this is some data from suggesting that maybe you can try to use a CXCR antagonist. And in this paper from a few years ago, they found that these GH cell granografts immune deficient nude mice responded very well to this anti-CXCR12 therapy. Another paper, again, using another antagonist of the same cytokine, again found nice data a few years ago. And the two more papers in other type of tumors, anti-CCL2 and anti-IL-8, has been suggested that maybe they are good treatments for tumors. And it could be just theoretically that these could be potentially useful agents to manage aggressive pituitary tumors, because both IL-6 and CCL2 is present in these tumors. And I just would like to show you these data, which is clinically actually quite relevant. This is a paper which looked at tried to target PD-L1 with in a Cushing model. We all know that the checkpoint inhibitors can cause pituitary damage in patients who otherwise don't have a pituitary disease. So they try to turn this question around and see that can we use this effect of the the checkpoint inhibitors to actually treat pituitary tumors. So in this study, they compared in this Cushing model with ATT20 cells in the skin of the animals. And here are some human data of the same kind of story. Patient treated with ipilimumab and nivolumab and response to of the tumor, very aggressive tumor, to this treatment. And there are again 2 more papers from a different study, again ipilimumab and nivolumab treatment showing some effect in these patients. So especially in very aggressive cases, this might be something which we can use in the future. So in summary, I talked to you about the tumor and its environment. I suggested that there may be a certain immune infiltrate phenotype, which is associated with more aggressive tumor growth. There are tumor-associated fibroblasts, which make cytokines, and maybe if you can have an effect on these fibroblasts, that could be beneficial for the tumor growth. And we suggest that because of the SSTR1 expression pasireotide, it could have this effect. We suggest that AIP positive tumors contain more macrophages and they have more typical, more prominent epithelial to mesenchymal transition changes. And we found specifically that CCL5 may be a potential treatment option. So overall, novel treatments targeting the tumor microenvironment may have a potential in management, especially in patients with more aggressive tumors. And with this, I would like to thank my colleagues who did these studies, Dr. Barry and Dr. Pedro Marquez, and of course, all my colleagues. Thank you so much for your attention.
Thank you so much, Dr. Kabnitz. Dr. Murali, should we take some of the questions in the chat box? You're on mute, I think, Murali. Okay. Professor,
can you take over, please?
Sure. Professor Corbinus, if you don't mind, we'd like to ask you to respond to some questions which are there in the chat box. The first one says, does the invasion result in an increased M2 infiltration, or are the M2 macrophages contributing to the invasion? So is it a cause or effect out there?
Yes, that's a very good question, and I'm not sure I can answer, because as I showed you, both the immune cells have an effect on the tumor cells, but I can also show that the tumor cells have an effect on the immune cells. And I showed you that supernatant from the AIP knockdown cells were attracting more macrophages and made the macrophages more active than in the GH3 cells, which are also pituitary tumor cells, but with normal amount of AIP. So this might suggest that maybe the tumor is the kind of out of the chicken and the egg situation. Maybe the tumor is the one which starts, and the tumor releases some cytokines and chemokines, which then attracts the macrophages, and then the macrophages and all the other immune infiltrates, then they make the tumor more aggressively growing and create an environment for advantageous environment for invasion, which could be the case. So yeah, if I have to make a decision, I would say that it's the tumor cells.
There's another question which says pituitary carcinoma is less common compared to other endocrine glands. Would you like to speculate or say why?
Yeah, so we will hear Professor Malmed in a few minutes, and he of course suggested that this could be because there is a kind of a natural cell death within the cells, and therefore they don't come to the kind of cancerous stage. So what they call oncogene-induced senescence could be one of the options why this occurs, and therefore these tumors don't turn into pituitary carcinomas.
Dr. Pathak, would you like to ask your question yourself?
Thank you very much. I'm just a simple bread and butter neurosurgeon, but interested in the field very much. I've done about 1,500 operations on pituitary tumors. I would like to know, it's a very fascinating talk, first of all. Thank you very much. Is there a difference in the molecular environment for invasive tumors in contrast to those which simply recur without invasion?
So I showed you some data both from our groups, but also group from Paris and also, sorry, Lyon, and also from Canada, that they suggest that, yes, there is a difference in the immune environment between invasive tumors and non-invasive tumors. So the very short answer is yes.
Right. And what about any environmental difference between microadenomas and macroadenomas? Because why these tumors are small and the others grow? I mean, is there any environmental difference which promotes their growth?
Yes. So to be honest, I am unable to answer that question based on our data, because when the surgeon operates the patient, they give us a bit of the tissue to study, which is not essential for the clinical diagnosis. And
Right.
they usually can give us tissues from macroadenomas. For microadenomas, the amount of tissue we get is either zero or very small. So we are unable to do proper studies on microadenomas, and I cannot answer that for your question. Practically all our data is on macroadenomas.
Right. And if I take the same question further, is there any way to predict apoplectic events based on the environment? Apoplexy, why does it happen in some, doesn't happen in others? Is the cell environment, can it give any clue?
I haven't actually heard fully your question. Some of the words got lost. Yep. So if I understand properly, are you asking that why some adenomas become invasive and others don't?
No.
Apoplexy.
Can we predict apoplexy based on the cell environment?
Apoplexy.
Right.
Again, I don't have data to give you on that, because I mean, I actually had pituitary tumor coming to the lab for research, which was from a patient who had apoplexy, but the cells are dead and they not grow. Right. So I can't study them. Right. But regarding apoplexy, there are data from Japan suggesting that if you leave a non-functioning pituitary adenoma, which you don't operate, let's say it's not approaching the optic chiasm in a dangerous way, or doesn't give the patient symptoms, or they are hypopit already. So in those patients, you have a high chance that, well, not high, but a certain chance to at some point get an apoplexy. That's one. The other is that with patients with AIP, we see apoplexy more often than without AIP, and especially with the apoplexy, even children, which is otherwise extremely unusual. So that might be related to the rapid growth of the tumor. We try to see that whether we see kind of differences between AIP positive and AIP negative tumors in the vasculature, but so that's a study which we actually haven't published yet, but it would be interesting to look at. We also looked at our animal model, AIP related tumor, whether they have more apoplexy or differences in the vasculature. But the problem is that our control in the animal model is a normal pituitary, which is not really a good control. Right. What you want is another tumor due to another gene, let's say. So you can compare tumor to tumor. So we can do that on the human samples. It's a bit more difficult to do that on the animal studies, to have the appropriate other tumor control.
Thank you. And just to conclude my last question, I'm sorry I've asked a lot of questions. Temozolomide has been claimed to contain aggressive and invasive tumors. How far is that acceptable to you?
To give temozolomide to patients? Well, the ones which need it, yeah, it's very acceptable. It's luckily it's a small percentage which needs it, but those ones who need it, they benefit, and at least for quite a few months, you can control tumor growth quite nicely.
Thank you very much.
Dr. Muralidharan, you had a couple of questions, perhaps if you could go next.
I was intrigued by the different behavior of immune cells on different tumors. For instance, the conventional teaching has been that immune cell infiltration is anti-tumor, in CA breast, seminoma, in many germ cell tumors. So in pituitary, do you have such data where in some scenarios it has anti-tumor effects, the infiltration, or different types of infiltrates, like you showed macrophage 2 versus macrophage 1, whether there is any specific cell type which can have anti-tumor effects rather than pro-tumor effects?
So the data, what we found is that we found that I totally understand your question, because sometimes you don't know, is it good to have immune response because that then can kill the tumor, or is it bad to have tumor response, immune response, because that makes the tumor more aggressive? And it's kind of a two-edged sword, this whole immune response to tumors. And our data suggest that the cell types which I showed you, which is the macrophage, especially the M2 macrophages, the CD4, the Treg, if you have high levels of these, that is not good news for the patient and not good news for the prognosis. Yeah, this is what we found, but I totally agree with you that this could be could have happened the other way around, or at least for some cell types, but we haven't found significance in the other direction. We only found significance in this direction, like the more aggressive direction.
My another quick question will be, you said about SST1 receptor ligands acting on, other than the somatostatin receptor, on the tumor microenvironment. We have data on dopamine also, whether cabergoline has similar effects.
I don't know. We didn't look at the effect of cabergoline on the tumor associated fibroblast. We have not. So the reason why we haven't done so much cabergoline work, because we have very few prolactinomas operated, very few. So again, to have a reasonable N number, it's you need years and years, and usually you have your fellow doing a study not more than 3 years. So if in 3 years we can't collect enough operated prolactinomas, to do a study, then you just, so I don't have the data.
Thank you.
Dr. J.D. Mukherjee, do you want to follow up on that?
Sorry, I'm muted. Hi, Martha. Nice to see you. Looking good as ever.
Thank you. Hi, JJ.
I was coming to the macroprolactinoma story. You see, if there's one pituitary tumor which responds to medical therapy, that's a macroprolactinoma. And it would be really nice to see all the things that you've very nicely shown. Very nice talk. Thank you. What are the changes in the microenvironment? That would be a big plus, that one tumor is shrinking. Now, as you rightly mentioned, getting the tissue. So my question was, is there any animal model that you can think of where you can do this kind of study?
Yeah, so there is an MEN1 knockout model, and they have prolactinomas. So that would be a model to do a study on prolactinomas. Also, the Lyon group has a very interesting kind of tumor model with prolactin secreting tumors. I think it's actually not in mouse, but in rat. And so they have a model where they could do this, but I don't know if they've done that. So maybe the MEN1 model would be the one which is like widely available where this could happen. In the AIP knockout model, interestingly, the majority of the lesions, we found multiple lesions within the pituitary in these animals, and some of those are prolactinomas, so not all of them growth hormone. The majority are growth hormone, but we found prolactinomas as well. But we only know which is the prolactinoma when we cut it out and do the staining, and then we can see. So we won't be able to do like studies on a fresh model. So I think that maybe the MEN1 model would be the one to do this sort of studies with cabergoline, which then gives you information of the MEN1 related prolactinomas, but how much it's relevant to the ordinary prolactinomas, I don't know.
Thanks.
Thank you. If there are no more questions coming up or comments, I think in the interest of time, we'll have to tear ourselves away from you. Thank you so much. This was really spectacular, and we enjoyed ourselves thoroughly. And I will hand you back to the organizers.
Thank you so much for the lovely questions. Thanks.
Thank you, Professor Kobonitz and Professor Singh, for that extremely novel and captivating talk. Without much ado, it is now time to move to another exciting session that is just about to come up in a short while. So the first exciting talk on the genetics of adrenal insufficiency, may I please invite the chairpersons, Professor Anil Bansali sir, Professor Nalini Shah ma'am, Professor Ish Bhatia sir, and Dr. Rama Walia ma'am to introduce the speaker and chair the session. Chairpersons and speakers, please.
Share screen. Thank you. Thank you, Lisa. I, on the behalf of my other co-chairs, have a pleasure to introduce Professor Lou Methril, who is a professor of endocrine genetics and has got a lot of work in adrenal insufficiency. She will be going to present her work on adrenal insufficiency, the genetic basis for that. Professor Methril, please.
Hi, good morning, good afternoon, good evening to everybody. Okay, I'll just share my slides. Hopefully you can see my slides now.
Yes, ma'am, we can see your slides. Please go ahead.
Thank you. Okay, so I'm going to talk to you today. I'm going to do a whistle-stop tour of adrenal insufficiency and the genes that cause it. But basically, to try and put this in a bit of context, since I'm in a pituitary meeting, you have both primary, secondary, and tertiary adrenal insufficiency. Today, I'll be talking to you mostly about primary adrenal insufficiency, where you get a failure of the adrenal glands to secrete one or more hormones. You can also, of course, get secondary insufficiency due to hypothalamic or pituitary defects, so multiple pituitary hormone defects or absence of POMC or TBX19. And tertiary can be due to suppression of the adrenal axis with exogenous GC treatment. Now, for PAI, as I'll call it, in adults, it's most commonly autoimmune, leading due to Addison's disease. But in childhood, it's usually congenital. And there's an increasing number of gene defects that cause it, some of which are syndromic, and some of which are sort of isolated adrenal insufficiency. And so you can classify adrenal insufficiency in many ways. And another way of classifying it is to look at it in terms of the pathways that it affects. So if you look at this international classification that was recently performed by these eminent people, can you see my mouse? Lisa?
Yes, we can see.
You can see me indicating, thank you. So obviously there are steroidogenic defects in the steroidogenesis pathway, FGD-like, which is where I come in probably, mostly. There are hyperplasias and there are sort of other weird and wonderful adrenal insufficiencies, and of course these secondary ones that I talked about. So if we look first at the sort of steroidogenic pathway, the most common defect obviously here is congenital adrenal hyperplasia, and all of these other ones that I'm going to talk about are much rarer. So increased adrenal androgen output is obviously a consequence of congenital adrenal hyperplasia. So here the phenotype will be virilization in utero of female fetuses. You usually have cortisol and aldosterone deficiency. And yeah, because of the excess adrenal production, you get this virilization. And this is, so CYP21 defects, CYP21A2 are responsible for about 95% of CAH, with these others causing many fewer cases. And STAR and CYP11A1 are kind of special cases, which I'll come back to, because we found mild defects in these genes, which cause a much milder phenotype. So these FGD-like ones, which is really where my work over the last 20 years has been, can be caused by gene defects in these genes that I'm indicating here. And these are much rarer than CAH. So a kind of estimate of 1 in 200,000 is a sort of high-end estimate for something like MC2R in the Irish population. So what am I talking about when I say FGD? I'm talking about isolated glucocorticoid deficiency, so the sort of simplest adrenal insufficiency. And it's a rare autosomal recessive disorder caused by resistance to the action of ACTH, isolated glucocorticoid deficiency, and obviously fatal if not recognized and treated. Patients present with neonatal or childhood hypoglycemia and jaundice, and biochemically have low or even undetectable serum cortisol coupled with elevated ACTH, and normally the aldosterone is normal. And this can lead, this elevated ACTH can lead to hyperpigmentation, as you can see in this child who has an MRAP mutation. So neonatally, there's hyperpigmentation. After 6 months on treatment with hydrocortisone, this has almost disappeared. So, as I said, there are different pathways that can be affected. And for FGD, we have defects both at the receptor level, so in the cell surface, where the receptor for ACTH is deficient, or its accessory protein, then come into the steroidogenic pathway. I'm going to come back to STAR and CYP11A1, as I say. And then there are these weird and wonderful defects of reactive oxygen species detoxification, which we've discovered recently, which I'm not going to talk about very much today. The first gene defect, which was discovered by my former boss, Adrian Clark, in 1993, was a deficiency of the ACTH receptor itself. It's also called the melanocortin 2 receptor. And there are many, many gene defects that have been described since then. And perhaps to note, there are familial and also ethnic variants. So, for example, the S74I variant is very common in the UK population. Similarly, the melanocortin 2 receptor accessory protein can also be defective. And this was described by me in 2005. And there have been less varied mutations in this gene, but again, these there are sort of regional variants. So this particular one here is very common in the Turkish population. So obviously, if you're doing a sequencing of a patient, then it may serve you well to look at particular genes and particular regions of particular genes. And as I say, getting on to STAR and CYP11A1, obviously, usually these cause both adrenal and gonadal failure. But we and others have described mild variants, which cause just isolated glucocorticoid deficiency, or maybe glucocorticoid deficiency with DSD. So we described, we and others have described, in particular in the STAR gene, some variants, these ones highlighted in green here, which give rise to a non-classic lipoid congenital adrenal hyperplasia. So these patients don't get the huge lipid-laden adrenals that you see normally. Similarly, there are mild variants in CYP11A1, and we described this, we and others actually have now described this particular variant, which is common in Europeans, in compound heterozygosity with severe variants on the other allele. And this actually is as I say, relatively rare in the rest of the global population, but actually in Europeans, 1 in 120 are carriers. It's useful to look at that in European populations. And in this paper, which we published in 2018, we found this variant in compound heterozygosity with one of these ones in red, or even with these two here in green, which are actually silent mutations. We went on to prove that both these two and this one are actually splicing defects. And so in collaboration with these really deleterious variants in the other allele, they actually cause the disease, but it is relatively mild. So in the paper, we described 19 individuals coming from 13 families from across the world, actually, but they're almost all of kind of European extraction. And the age at diagnosis was median 4 years. Some of them had convulsions, and some were hyperpigmented. And 8 out of 19 at some stage during their life course required mineralocorticoid replacement. For the most part, they were normal genitalia, but obviously going forward, there needs to be careful monitoring of testicular function for these patients. And as I say, these were the sort of mixture of variants that we found. We actually found that in our undiagnosed primary adrenal insufficiency cases, actually 1 in 8 patients were carriers. So I've talked about the variants in this part. So at the receptor level at the cell surface, these strange mild variants in strongyl-CYP11A1 giving an FGD phenotype. And then we've more recently described variants in NMT in a number of patients that give rise to adrenal insufficiency, and also in TXNRD2 in one particular family from Kashmir. And these are genes which are responsible for antioxidant defense in the adrenal. And it may be that the adrenal is especially affected because this process of steroidogenesis is extremely oxidatively stressful. It creates a lot of reactive oxygen species. So if we look at the genes that I've described so far, which are mostly adrenal insufficiency genes, so looking at the FGD-like ones, almost invariably they just cause an adrenal phenotype. For most of the other steroidogenic genes, you get both adrenal and gonadal hormone deficiency. So these are the kind of simple cases. But if I can switch to something a bit more complicated, so I'm not going to talk about all of these genes, but I'm going to talk in particular about our discovery in SGPL1, and then a little bit about these other syndromic causes of adrenal insufficiency. So this was a complete surprise to us. We found variants in SGPL1, sphingosine 1-phosphate lyase. And this is the enzyme that's responsible for the final decisive degradative step in the sphingolipid pathway. So it converts sphingosine into these products, and there's no reversible reaction. And previously, no mutations have been associated with human disease. However, other enzymes in the pathway have been known to be associated with sphingolipidoses. And these are multisystemic disorders, but no previous adrenal pathology had been described. And in 2017, we described 5 families who had mutations in SGPL1 and a variable phenotype. So almost all of them had adrenal insufficiency, and many of them had steroid-resistant nephrotic syndrome. It was inherited in autosomal recessive fashion. So we went on to show that the lyase activity of these mutations was absolutely null. And this caused, as you might expect, an increase in the sphingolipid intermediates upstream of the gene defect. And in particular, actually not S1P immediately upstream, but actually the sphingosine ceramides were much higher. So here we're looking at a patient with an age-matched control, mum and dad, again with age-matched controls. As you can see, there's a vast increase in the ceramides, whereas it's not so different from the parents in the S1P. And in our cohort of patients, there were a number of pathologies. So as I say, most of them had adrenal insufficiency. They presented at various different ages, the oldest being 17 and a half, mostly hyperpigmented. This one was diagnosed earlier because of a sibling. 5 out of our 8 had steroid-resistant nephrotic syndrome, but 3 did not. There did not seem to be a genotype-phenotype correlation since this patient did have a renal phenotype. The ichthyosis was not described in these patients, but for the other 4 out of 5 had ichthyosis. And we also saw sensory neural deafness and neurodevelopmental delay in some patients. So clearly, this is a multi-organ pathology. So I'm not going to go into detail for the other syndromic adrenal insufficiencies, but just to say that over the last 10 years, at least 4 different syndromes have been described, which have adrenal insufficiency as one of their features. So we described MCM4 mutations, which cause natural killer cell and glucocorticoid deficiency with DNA repair defect. It's also got immune deficiency, and it's also called IMD54, so it gets quite complicated. In 2016, a Japanese group described mutations in SAMD9, which cause mirage, which is a syndrome of myelodysplasia, infection, restriction of growth, genital phenotypes, and enteropathy. And then there are 2 similar gene defects, one caused by POL-E, and the other one called by CDKN1C. So the image was described first, which is IUGR, metaphyseal dysplasia, adrenal hyperplasia congenital, and genital anomalies. And then image I, due to POL-E deficiency, has the same syndrome, but also immunodeficiency in some cases. So as I say, primary adrenal insufficiency is getting extremely complicated. There are many different genes and pathways that are involved. So looking at this schematic, there are cell membrane defects. There are all these defects in steroidogenesis in the mitochondria and nucleus and the endoplasmic reticulum. And these strange defects in antioxidant defense within the mitochondria, which we're working on trying to understand why this happens. So if we add on to the non-syndromic adrenal insufficiency genes, the syndromic ones, you can see that for many of these, there are a number of organs that are affected, some of which are endocrine and some of which are not. So it's becoming increasingly complicated to diagnose your patient when you meet them in clinic. And obviously, from my point of view, genetics will be the way to go. So you've got no overlapping phenotypes. It would be quite difficult to judge what the defect is on first look. So we have a cohort of about 400 families, and these come from 33 different countries. And within this cohort, we've been the first to describe a number of gene defects. We've also described some weird and wonderful, as I was saying, partial defects in some of these genes like CYP11A1, where you've got benign or silent variants which actually are splicing defects, and so cause a sort of milder disease. We discovered along the way that many of these patients have a really long diagnostic delay. So many of them have like 6 years before they find out what their gene defect is. And this is showing the patients where we've actually solved the diagnosis. We have another 100 plus where we don't know what the gene defect is. So I guess in conclusion, my take on it as a geneticist would be that to study the genes is the way to go for diagnosis. And I've had many arguments about this before, so I'm very happy to hear your opinions. This is my final slide where it's acknowledging some of the people who've been involved in this work over the years. I'd also like to thank my funding bodies and obviously patients, families and other referring clinicians that I haven't mentioned here. And just a little plug, if anyone has a patient they would like diagnosed, please feel free to contact me. Thank you for your attention. Happy to take questions now or by email if you want to speak to me later.
Thank you. Yes. Thank you, Professor Methrin, for a lucid presentation. And we do understand adrenal insufficiency is a rare disorder, but still a lot of genetics have been done for this rare disease and very deeply rich in most of the genes which you have identified, and you have worked on that. So if there are any questions or comments, and my co-chairpersons, do you have any questions or comments?
Yeah, maybe I can ask
Dr.
Mathur a question.
Dr. Ish, yes,
I'm
yes,
Dr. Ish
yes.
Bhatia.
Yeah.
That was an excellent talk.
Thank you.
And I just want to ask you that in AAA syndrome, I mean, you have, of course, primary adrenal insufficiency, but you also have, lacrimal gland involvement, and you have achalasia. And so what is the basis for such varying kind of presentations, clinical presentations?
I think, with many of these gene defects, it's because, let me start with the other way up, I guess. So in these syndromes where you've got, let me just share that one again. In these syndromes where you've got, isolated adrenal or gonadal involvement, it's usually because these genes are restricted to those tissues. And so, obviously in AAA, the expression of the gene is more widespread. So when defective, it can be causing these other issues. But I mean, your point, I understand the question, because obviously things like the NNT gene and TXNRD2 are ubiquitous genes. And we still don't really understand why it particularly hits the adrenal.
Right. And what is the basis for the adrenal insufficiency in AAA syndrome?
The AAA syndrome is a disorder. So there it's the microtubules and the separation of the sister cells, isn't it? From memory.
Okay, Professor Methrin, how common is your AR mutation?
AIRE?
Yeah, AIRE mutations in your practice?
I'm not sure, actually. I mean, all of these gene mutations are extremely rare.
But I think the most common which you have shown in your results is MC2R.
I didn't hear you. So in our cohort, these MC2R and MRAP are the most common, but this was a sort of biased population because these patients were sent to us as isolated.
What about the?
May I ask one question?
Mary, yes.
So, ma'am, how do you go about which gene to look for? It's whole exome sequencing, or you go step by step?
That's a good question. Yeah. So what we tend to do is we have a pipeline where, for us, we look at. In fact, I've got it here. Put that up. So this is our protocol, basically. What we do first, if we do candidate gene sequencing.
Okay.
So we look at the most commonly mutated genes, so MC2R, MRAP, STAR, and CYP11A1. So these are the most common genes for us. And if we find those, then we go to whole exome sequencing, because once you go past sequencing these ones, it's more economical to do a whole exome. And then in those where we don't find anything in the genes, sometimes we even go to whole genome, try and find something new.
Can I ask one more question while we wait for people to put a question in the chat box? And that is is there a difference in prognosis of patients who have familial glucocorticoid deficiency versus patients with autoimmune, for example, autoimmune primary adrenal insufficiency? Is there some long-term study of these patients?
Sorry, did you say or prognosis?
Clinical prognosis, as what is their life expectancy, or what is it the same as any patient with primary adrenal insufficiency, the common variants?
So obviously, I think the danger for patients with FGD is that the onset is in childhood. It's often neonatal. So many of these families, there are a number of deaths before the syndrome or the gene defect is recognized, versus Addison's, which is later onset.
Right.
It can still be lethal.
Ma'am, how do you dose these patients? What dose of hydrocortisone and how do you titrate?
I'm a basic scientist.
Okay.
So I leave that to my clinical colleagues who have better knowledge than I.
Dr. Mathur, in patients who have SGPGL1 deficiency, which you so well described recently, they have a very wide differences in their presentation. Some of them have neurological deficits, some of them don't have, and some of them have nephrotic syndrome, some of them don't have. So is there some, so is it just that when you have gone through the more common genetic causes of adrenal insufficiency, then it's just that one has to just do go ahead and just is there any specific combination or any specific time you think we should consider this syndrome, or we should just think of it as if we get it, we'll get it when we do a whole exome sequencing?
Yeah, so it's difficult. So obviously the first family that we found, which was the one with the multiple affecteds. I can go back.
Thank you. Thank you,
So
Professor.
going back, the first family we found, the first mutation was in this family, who really had a relatively mild end of the spectrum disease. So for most patients, it's severe disease. And I think of the 30 or so cases reported, more than half of them have died. So, and some of them have hydroxyphenols. So it really is a really broad spectrum of disease that this causes. And we can only assume that it is genetic background that this mutation is on that causes the variability that we're looking at, but obviously we have small numbers, so it's quite hard.
Right.
Thank you. Thank you, Professor. And thank you for very nice conversation and discussion. So
thank you for inviting me.
Yeah, and I will hand over mic to now organizers. Thank you.
Thank you, sir. Thank you, chairpersons, and thank you, Professor Methril, for that very lively talk. And it is now time to commence the next talk, which is to be delivered by none other than a doyen in the subject on the topic of personalized management of acromegaly. So may I please invite the esteemed chairpersons for this session, Dr. R. Muralidharan, sir, Professor Nihal Thomas, sir, from CMC Vellore, Professor Ari Chako, sir, and Professor Shubhankar Chaudhary, sir, from IPGMR. So chairpersons are requested to kindly introduce the speaker and conduct the session. Thank you.
May I have the introduction slide of Professor Melme? Very good evening, and we have come to a very important session from the doyen himself, an authority on this subject, and all the endocrinologists in the country and the whole world will know him as the leading author as well as the editor of Williams' textbook of endocrinology, the Bible. And he's going to talk on a very fascinating topic, that is personalized management of acromegaly, because precision medicine is the holy grail of every medical specialty, and that's better achieved in some areas, whereas research is going on in some other areas. And there is some literature coming up in acromegaly now, how to individualize management depending upon the patient characteristics as well as some tumor characteristics or some biomarkers. And we would love to listen from Professor Melme on this very important topic, how to optimize management, how to be cost effective in our management based on a personalized approach rather than a one-size-fits-all approach. Over to Professor Melme, please.
Thank you, Professor Muralidharan. I'm going to share my screen. If you can you let me take over the screen?
Yes, please.
Can you see my screen?
Yes,
Can you?
Yeah.
Okay.
Yes, sir.
All right. Well, thank you so much to the organizers for inviting me to speak to this fascinating meeting. And the first three talks have been terrific. And I hope that we can continue the dialogue at the end of my talk. So what I'd like to do is, first of all, disclose my conflicts to you, and then start off with the basics. When we approach a patient with acromegaly and we're really trying to personalize the treatment for that patient, the most basic question is, what's the cause of acromegaly? Because all acromegaly is not the same. And really what I'd like to do is divide acromegaly into three categories: primary growth hormone excess, primarily from a pituitary tumor; extra pituitary excess of growth hormone from ectopic production of growth hormone, which is extremely rare; and finally, GHRH excess, growth hormone releasing hormone excess, which may be derived from a tumor of the hypothalamic region, or more commonly from a carcinoid neuroendocrine tumor. And the majority of patients with acromegaly will indeed have a pituitary adenoma. And there are multiple forms of pituitary adenomas, and we don't really have time to go into them now, but it's very important before you start treatment that you understand the etiology on the pituitary side in this blue box, which is determining your patient's syndrome, because treatments will be different for each of these subtypes of pituitary causes of acromegaly. Very, very rarely, you may encounter a patient with a pancreatic tumor or a lymphoma with ectopic growth hormone and a normal pituitary. And then, of course, the patients with ectopic GHRH production are usually those with quite evident carcinoid syndrome, accounting for the vast majority of these patients. And then there is a new one, which I've listed in the middle here as iatrogenic. The new cause of acromegaly is patients abusing growth hormone. And I'm sure that you, especially in the big cities, encounter patients who buy growth hormone illegitimately or illicitly for athletic purposes. Doping in our athletes is very common with growth hormone, and also trying to reverse the frailty of aging inappropriately. And we've actually had patients who are presenting with acromegaly, as exemplified in this case over here, by abusing growth hormone. So the message from this slide is, before we can embark on a personal approach to acromegaly, we have to understand the etiology. Regardless of the etiology, the impact of growth hormone and IGF-1 excess is quite negative. Patients develop hypertension, cardiomyopathy, and valve disease. Cerebrovascular accidents and strokes are not uncommon. Gonadal dysfunction occurs. There are hard, bony changes of the teeth, which you're all aware of, and what's become more evident today of the presence of vertebral fractures, as exemplified in this patient, which may be asymptomatic and undiagnosed unless you look for them. Soft tissue tumors, especially in the colon. Diabetes for two reasons, because growth hormone impacts the pancreas directly as a target for the hormone, and also growth hormone acts at the periphery to block insulin action. In fact, growth hormone itself is one of the most potent blockers of insulin signaling, and that may be one of the reasons why we encounter women with gestational diabetes, because of the powerful anti-insulin action effects of growth hormone. Sleep apnea occurs because of the soft tissue swelling in the airways. And then don't forget in the center that this compressive mass is going to cause hypopituitarism as well, if the underlying pituitary function is in fact attenuated and compressed by the expanding mass. So these patients have a very, very broad spectrum of comorbidities. And I just wanted to give you one example, which was beautifully exemplified recently, of a patient exhibiting both the hard bony changes exhibited in the maxilla and teeth, as well as the soft tissue changes in these large polyps and swelling of the airways, which exemplifies both the soft tissue swelling and the hard bony changes in the same patients. The most important concern why we have to focus our treatment and optimize our treatment is the fact that these patients, if untreated and uncontrolled, have accelerated circulatory deaths and accelerated cerebrovascular deaths. So that is our clinical challenge. So how do we approach them? We approach them by eliminating their morbidities, reducing mortalities, and we're going to talk a lot about enhancing their quality of life. The strategies that we're going to have at our disposal today have to be safe. We should aim to control the mass effects, to control growth hormone secretion and action, but at the same time to make sure that we're preserving underlying pituitary function. And we assess them by, in the main, long-term by age-adjusted IGF-1 levels and improved comorbidities. So this is the background context of an approach to personalized therapy. So let's start with a patient, with a person, an individual. This is a young, newly diagnosed acromegaly patient. She presents with excess sweating, jaw prognathism, headache, arthritis, and hypertension, and her IGF-1 is clearly very, very elevated. And there you can see her tumor, which is lifting the optic chiasm on the north, and on the east and the west, she's invading the cavernous sinus. This is a macroadenoma, hypersecreting growth hormone. She sent for surgery, and 24 hours after resection of a sparsely granulated growth hormone secreting adenoma, her random growth hormone is still high. It's 2. It should be less than 1 randomly. 6 months later in follow-up, her IGF-1 is still elevated. And at that point, somatostatin receptor ligand, SRL therapy is initiated. So this is the patient. How do we offer her a personalized approach to her management? Well, we have 6 or 7 markers which we can utilize today to determine for us some inklings of the beginning of a very, very well thought through approach to personalizing our management with clear biomarkers for outcomes to these patients. Hormone granularity is one of them. So whether the granularity of the tumor is sparse or dense in terms of growth hormone granules will be an important biomarker of successful outcome or not. The presence of a specific receptor on the tumor, SST2 or SST5, the two somatostatin receptor subtypes, or even the dopamine receptor. The intensity of the MRI may also be a determinant, a biomarker determinant of responsiveness to treatment. The age of a patient will be a determinant, will be a very important biomarker because younger age patients do poorly, whereas older patients do much better in terms of their outcome. Cell cycle markers are important, and it's important to get this from your pathologist because the presence of a high Ki67 or a P21 will be a portender of a poor outcome. And the presence of cell-specific transcription factors, and the one for growth hormone, which is the most important one, is PIT1 or PU1F1, is very well established today, and the pathologist can stand for it, but it's not much help in your decision-making as a biomarker for therapy. Tumor proliferation is very important. The tumor size and the tumor invasion is going to be an important biomarker in determining your personalized approach. And finally, although the mutations are very well characterized, and Dr. Corbonitz, who spoke to you earlier this morning, was really one of the original discoverers of the AIP mutations in these patients. And the earlier studies on the GSP mutation from Italy, from Anna Spada, all are very, very important in terms of characterizing the phenotypes of these tumors. But at the moment, the application to long-term therapeutic outcome is as yet unclear in the sporadic non-familial cases. So let me give you an example of taking those biomarkers and putting it in the context of two patients. This is on the top, we have a patient who is relatively middle-aged or old, depending on your age. For me, she's young. For many of you, she will be old, but you can see she has a small tumor, characteristic of the elderly patients. She has a microadenoma, densely granulated with growth hormone granules, and you can see the growth hormone granules here densely packed in the microadenoma as compared to the younger patient with a large invasive macroadenoma, sparsely granulated, and you can see on EM over here, she has these sparse growth hormone granules, and the phenotypic outcome is different for these two categories of patients. And post-surgical disease persistent will be more prevalent for the patient with a macroadenoma, the paracellular extension, the younger age, the higher IGF-1, and most importantly, the choice of the neurosurgeon, with neurosurgical experience being a significant, statistically significant determinant of outcome. Not the expertise of the neurosurgeon, because all neurosurgeons who are qualified are experts. It's the experience in operating on pituitary tumors. And we've taken all that information and we now categorize our patients into three types, type 1 through type 3. Type 1 being those with the small microadenomas, and type 3, the large invasive macroadenomas. The microadenomas are associated with dense granulation, no invasiveness, and in contrast, the type 3 are the patients with the macroadenomas sparsely granulated, and the immunoreactivity for Ki67 is high. 42% of our patients with type 3 have a Ki67 greater than 3, whereas 90% of those with type 1 have a Ki67 of less than 3. Indicating low proliferative activity. The biochemistry is also different in that the type 3 patients have higher IGF-1 levels, whereas the type 1 patients have lower IGF-1 levels. Type 3 patients may require more than one surgery and sometimes more than 2 surgeries. They require very, very aggressive therapy, and ultimate long-term control is achieved in the minority of patients with type 3, whereas there is frequent control achieved in patients with type 1. So take the patient that I presented to you. She clearly fits into type 3. She has a large, aggressive, sparsely granulated macroadenoma. Her outcomes are going to be adverse despite more treatments because she is so young. And therefore, she requires a very, very focused, aggressive, personalized approach. And we have tools today which can enable us to offer her an optimal outcome for her disorder. So obviously, the first tool we have is the consultation and the expertise of our neurosurgical colleagues, either for microadenomas or for macroadenomas. However, the advantages of surgery, the rapid growth hormone decrease, the one-time cost, the potential cure, and the debulking to enhance subsequent adjuvant medical treatment have to be balanced with the disadvantages. And the most important disadvantage of surgery is that tumor persists and the growth hormone hypersecretion persists, just as it did in the patient that I showed you. Patients are at risk for hypopituitarism, and not all patients with acromegaly, especially those with florid disease or the more elderly ones, are appropriate candidates for surgery. The risks of surgery are well known to this audience. There are overall complications, diabetes, insipidus, especially transiently may occur, electrolyte abnormalities, neurological deficits, and CSF rhinorrhea occur postoperatively. And unfortunately, this is a general anesthesia. So like for all surgeries, there is a small, but definite, very small risk of mortality. The more complications occur in those patients with more comorbidities, and again, to re-emphasize, the surgical volume is a very, very important determinant of reported complications. So what about the medical approach? Well, the medical approach is based on our underlying understanding of the pathophysiology of the disorder. So growth hormone releasing hormone derived from the hypothalamus and ghrelin derived from the gut act to induce the somatotroph to produce growth hormone, whereas somatostatin acts to suppress growth hormone production by the somatotroph. And somatostatin signaling to the pituitary is mediated by receptors sitting on the cell surface of the somatotroph cell. And the one that we are most interested in is SST2, and less so, but still very important for therapy, SST5. And these two receptors sitting on the somatotroph are important determinants that have been exploited for therapeutic purposes. And the ideal is to change the pattern of acromegalic growth hormone secretion you can see on the right over here, which is erratic and wild, to that of the normal patient on the left shown, where there's normal growth hormone secretion with a burst of growth hormone mainly occurring at night and flat or undetectable throughout most of the day. Very, very rarely do we achieve recapitulation of the controlled growth hormone hypersecretory pattern. And because these patients' tumors express SSTR2 and SSTR5, the availability of a somatostatin agonist, a receptor agonist, is exploited to suppress growth hormone. The original work from Steve Lambert's, and I hate to think that it's so many decades ago now, 1985, showing that if you actually inject somatostatin analog, you will suppress growth hormone compared to placebo within 2 hours, and growth hormone will remain suppressed before it starts rising slowly. And the patient's soft tissue swelling, as exemplified in this patient with a macroglossia and a tracheotomy, is resolved within 16 weeks. So this is the application of the understanding of the pathophysiology to a personalized approach to a patient who does express predominantly SSTR2. In the USA today, we have available several drugs. we have 4 somatostatin receptor ligands. Lanreotide autogel, which is given 60 to 120 every 4 to 6 weeks subcutaneously. Pituitary and octreotide LAR, which is given Q4 weekly. And oral octreotide, which is given 40 to 80 milligrams daily in capsules. We also have available the dopamine agonist, cabergoline, which we give 1 to 4 milligrams orally every week. But I must say, I won't talk much about cabergoline because our experience with cabergoline is very, very dismal. We don't achieve success with cabergoline in our patients. And if we do, they require very high doses and patients are usually quite nauseated. And then we have available the other class, which is the growth hormone receptor antagonist pegvisomant, which works predominantly on the liver to block IGF production, in contrast to the SRLs, which work predominantly on the pituitary tumor to block some growth hormone secretion. However, none of these available medications, even if we're going to be personalizingly focusing them on the specific patient, are disease modifying. They all require lifelong application. We can individually titrate these patients, and I'll show you some examples, or we can combine them with each other in order to achieve optimal therapy. And we have to tell our patients that this will be lifelong therapy. So the question that we're all asking is, how effective are the somatostatin receptor ligands in terms of their efficacy in suppressing IGF-1 and suppressing growth hormone, regardless of which one of those 4 ligands that we use? And overall, we did a meta-analysis of all studies, controlled and uncontrolled, patients who had been selected or unselected for their trials in the literature, all published through 2014, and most of this data holds up today. Overall, about 60% of patients will exhibit controlled growth hormone as defined by that study, or controlled IGF-1 as defined by that study. There will be several patients in the upper right-hand quadrant in whom you will achieve universal control of their growth hormone and IGF-1. And there will be patients in the bottom left-hand quadrant of each graph who you will not achieve universal control. And this is the overall meta-analysis of the worldwide literature, which holds true today. So having said that, we now have availability of a new approach to delivering octreotide to the pituitary tumor, and that is using oral capsules. And the oral capsules contain the same octreotide. So whatever I'm going to talk about oral application now, it's the same octreotide that is in the injection, acting on the same receptor as the lanreotide in the lanreotide injection. All it is a capsule with combined surfactant and an oily suspension, mainly of fatty acid, to provide a transient permeability enhancer, a TPE, which is safe, which transiently opens the tight junctions and enables octreotide to enter the systemic circulation without chemical modification. And the first phase 1 safety trials in human volunteers show that if you look on the left-hand panel over here, that if you give an oral capsule of octreotide, you can measure basal growth hormone over 2 hours and show in the red that basal growth hormone is suppressed as compared to placebo in the basal untreated state, not acromegaly, healthy state in 16 healthy volunteers. Furthermore, if oral octreotide is given to volunteers 2 hours prior to GHRH or arginine, which elicits a brisk growth hormone response, you can blunt the response significantly by the pre-treatment with oral octreotide. And these were the first indications that the oral absorption, which I showed you on the earlier cartoon, is in fact bioactive in human patients. And the first phase 3 trial published showed that in patients who were previously responsive at baseline to injectable somatostatin analog, you can see the baseline GH on the left and the baseline IGF-1 on the right. The oral octreotide switch from the first dose all the way through 13 months maintains the control of growth hormone in these 151 patients who were treated, and the IGF-1 means are controlled for a period of 13 months after switching from the injectable formats. And in a subsequent paper looking at a placebo-controlled phase 3 trial, you can see that the patients have, compared to the placebo, have controlled IGF-1s and controlled growth hormones at the end of 36 weeks as compared to the exuberant burst of growth hormone or IGF-1 in acromegaly patients on placebo. There is a subsequent study which was just presented recently at the Endocrine Society in 2021 by Dr. Flescheroux that showed the results of the empowered study of oral octreotide, which showed non-inferiority when compared with the injectable. So you can see that there is an indistinguishable control of IGF-1 levels, both in terms of the output of IGF-1 as well as the number of patients controlled by either injectable in the green or the oral in the red, showing equivalence, showing actual equivalence of the injectable versus the oral. Not only was there equivalence in the study, but the patients reported improvements after switching from injectable to the oral somatostatin capsule were significant in terms of improved fatigue, swelling, treatment convenience, and treatment satisfaction. So we have all those somatostatin analogs, injectables or orals, which we can offer our patients. What happens if your patient, the one that we showed you, you've added cabergoline, you've given the patient a maximal dose of somatostatin receptor ligand, they're still not controlled. At this time, you can try pasireotide. And pasireotide is also a somatostatin receptor ligand, but pasireotide works on SST5, the 5th receptor subtype. And in this power study, you can see over here that in the green, patients who are uncontrolled in the green on octreotide, when you give them a pasireotide, IGF-1 levels will be suppressed and growth hormone levels will be suppressed in a significant number of patients. So pasireotide does appear to exhibit better efficacy than octreotide or lanreotide in any of their formulations. However, if you see on the right, pasireotide causes hyperglycemia in terms of fasting blood sugars, in terms of hemoglobin A1Cs, and these patients will develop diabetes. So this is a problem with pasireotide in terms of its, although it has improved efficacy, it does have the side effect profile, which is more deleterious than that of the octreotide or lanreotide formulations. So to summarize SRL therapy, you can see this patient here is with a large macroadenoma and acromegaly, chose to have primary treatment with a somatostatin analog. The tumor shrinks nicely. This is a beautiful representation of tumor shrinkage, but the patient developed gallstones. So although we do get rapid control and symptom relief in the majority of patients, no hypopituitarism and tumor mass is usually controlled. We don't often see such beautiful shrinkage, but the mass growth itself is controlled. These patients may develop gallstones or sludge. They get diarrhea, nausea, and abdominal discomfort. And hyperglycemia is especially important for pasireotide. Patients develop bradycardia. And for the injectables, there's injectable site pain. These are painful deep intramuscular injections or deep subcutaneous injections, and patients may develop alopecia. Again, to emphasize, the disease cure is not permanent. It is controlled. Long-term treatment is required. There's a sustained cost. And for the non-oral availabilities, these patients require long-term injection compliance, either in your clinic or in the hospital, and this is a disadvantage for patients. So let's assuming that the patient that you're looking at, the personalized approach to your patient, has not responded to pasireotide, has not responded to increased somatostatin receptor ligand, you can then try pegvisomant, which is the growth hormone receptor antagonist. And pegvisomant, to remind you, as exemplified in the yellow cartoon here, sits in the bi-arm of the bi-armed growth hormone receptor in the purple and the blue in the liver, and blocks the signaling of growth hormone on its receptor in the liver, blocking IGF-1 production. It does not act on the pituitary. And these patients, your goal is to normalize their IGF-1 levels, to control their symptoms, and overall efficacy does appear to occur in more than 70% of patients receiving 20 to 40 milligrams a day. The disadvantages, however, of pegvisomant are, well, firstly, it doesn't target the tumor. It only targets the peripheral liver. It requires daily injection. Rarely liver enzymes may increase, and rarely lipodystrophy has been reported. However, these patients, although this is depicted beautifully in the initial studies by Peter Traynor in the New England Journal of Medicine, now 20 years ago, you can see these patients, although they suppress their IGF-1s beautifully in a dose-dependent fashion, their growth hormone levels go up because you've removed the negative feedback inhibitory control of the peripheral IGF-1 on the tumor growth hormone production. So in effect, although these growth hormone levels are high, the growth hormone is bio-inactivated because the peripheral receptor is blocked. But nevertheless, you cannot measure growth hormone as a biomarker of successful treatment because it will invariably be high in these patients. So the question is, how many patients normalize their IGF-1 levels on pegvisomant? And we don't really know from controlled studies. All we know are the results of the surveillance, which is a non-controlled study surveying all patients receiving drugs. And this is the most recent surveillance of 1,450 patients who've been followed for 10 years in this surveillance of patients receiving pegvisomant. Again, this is a non-controlled study, purely observational, and you can see, well, 1,400 started, and after 10 years, there are only 105 patients. We don't know how many patients dropped out. So with that caveat, it does appear that in the red, there are about 25% of all the patients being surveyed who do not respond, whose IGF-1 remains above the upper limit of normal, and about 70% of patients in the black who do respond, whose IGF-1s are reported as normal. But again, this is uncontrolled, but nevertheless, it gives you a good snapshot of what you expect in the population from your patients receiving the growth hormone receptor antagonist. So let's assume you've given pegvisomant. At this point, what else can you do if your focused approach to your patient is not working? Well, we could offer these patients a combination of a somatostatin receptor ligand with pegvisomant, so-called combination treatment. And we've been very intrigued by combination treatment. I want to emphasize it's not approved in the label, and it's very expensive. So we were concerned about using a combination of somatostatin receptor ligand with pegvisomant because of its expense and the requirement for daily injections of pegvisomant and monthly injections of somatostatin. So we performed a study, a prospective study, which was only published last year, looking at 52% of patients in whom we prospectively categorized into 3 groups. The first group receiving high-dose somatostatin plus weekly pegvisomant, and to emphasize, that's not on the label is daily, or receiving low dose, the lowest possible dose of somatostatin receptor ligand with weekly pegvisomant, or daily pegvisomant with low dose somatostatin, which is what the label says. And we were surprised that looking at this controlled prospective categorization of patients, we were extremely surprised that they all normalized, regardless of the protocol, and that 96% of 52 patients uncontrolled at baseline, controlled after 6 months. Not only were they normalized on the low-dose weekly pegvisomant and low-dose monthly somatostatin, the cost was much cheaper. $9,000 wholesale costs in the USA versus $14,000 for this group and $22,000 for this group. clearly a major difference. So our approach today is low-dose somatostatin and weekly pegvisomant, although it is an unapproved on the label. So the rationale behind the combination of somatostatin receptor ligand and pegvisomant at the low dose, weekly pegvisomant and monthly somatostatin, is to hit the liver and hit the pituitary gland, to improve morbidity, to control IGF-1 in more than 90% of patients with uncompromised pituitary function. Tumor size is indeed controlled. Adverse effects are similar as to the monotherapies, and we can avoid less safe surgical treatments like radiation or repeat second or third surgery. And at the end of the day, this is going to be a patient choice. So if we assume that the patient still is not controlled, and there are very few left at this point of the paradigm, at this point of our flow chart, there are going to be very few patients who are not controlled. At this point, we would consider radiotherapy or repeat surgery. Now let me turn to quality of life for one moment before we end. And quality of life is really important. And there was a very interesting study that Dr. Eliza Geary in New York published, which came on the heels of a similar trial, which Dr. Strasburger published in a couple of years ago. And this looked at patients, these both looked at patients' symptoms. And it turns out that on injectable somatostatin receptor ligands in the red, there are dramatic increases of symptoms: headache, excess sweating, joint pain, swelling, carpal tunnel syndrome, snoring, visual problems, and the acromegaly fog at the end of the injection cycle. The last 5-6 days of the month after the injection, the symptoms exacerbate and seem to burst through the baseline, which would be further rationale supporting an approach of giving an oral capsule twice a day to prevent the breakthrough of the waning of the effects of the long-term 28-day injection. And we don't yet know whether this will occur, but now what we're doing is we're putting patients on the oral to sustain a plateau of somatostatin throughout the month so that they don't have these breakthrough symptoms. And in order to follow these patients, don't just focus on the IGF-1, even though the personalized approach will be geared towards following the IGF-1, we have to be concerned about their overall outcome. And this patient, we have to be concerned about her headache and her arthralgias, her cardiac failure, her hypertension. Will she or won't she develop diabetes? And most importantly, to prevent sleep apnea, and if it does occur, to treat the sleep apnea. We have to be concerned about endocrine replacement if there's compressive attenuation of pituitary hormone secretion. She may want fertility. She has a lot of self-image problems and anxiety, which we have to counsel her for. She may even require maxillofacial surgery for overbite or for TMJ, or even for cosmetic purposes. We have to help her interpret laboratory testing, because all these patients go on the web, they see the results. The IGF-1 assays are not good, as you well know. Even IGF-1 assays are all over the place, and patients get very, very stressed out when they get an abnormal IGF-1 results. And most importantly, whatever therapy we offer them are going to have side effects. And as endocrinologists, it is our responsibility to help them navigate preventing side effects, and if they do develop them, to switch therapies or to alter therapies or to combine therapies to try and attenuate the impact of the side effects. So to summarize, acromegaly is a process with a chronic growth hormone excess, usually from the pituitary adenoma. Unfortunately, when we see patients, because of the delay in diagnosis, they usually have advanced disease because of chronic IGF-1 exposure. Their comorbidities may occur if they're chronically uncontrolled. And we now have an armamentarium to offer them an integrated management approach based on biomarkers, which hopefully will become more precise as our translational science moves more and more into the clinic. So thank you very much for your attention, and I'm happy to answer questions. And thank you again for inviting me to join this interesting symposium.
Thank you, Shlomo. I think that was, everyone would agree that was a wonderful overview of the management options in patients with acromegaly. We do have a few questions in the chat box. Can we start off with this one? So we have a patient with a young patient with a large macroadenoma, maybe T2 hyperintense, suggesting sparsely granular tumor. So what would, apart from counseling, is there a difference in our start of treatment? For example, if there is a paracellular extension, is there any evidence that we start with SRL treatment and then shrink the tumor and then go for surgery?
That's a very common question, a very important question. And that's, in fact, that question is what the patients ask us, because clearly the textbooks and all the flowcharts say your step number 1 is surgery. The patient says, well, doctor, I don't want surgery. If the patient doesn't want surgery, we have a reasoned discussion with them, showing the benefits and the risks of surgery versus the benefits and risk of primary treatment with a somatostatin receptor ligand. If it's a large tumor and they're compressive signs, there's no question they need surgery right away to decompress. However, if it's a small tumor, there are no compressive signs, there's no danger of visual fields being impaired, then at that point, you can offer the patient the option of a primary medical treatment, and they can see how they do, and then you can go to surgery if it has been scheduled. What often happens is you give those patients a somatostatin prescription, they start the drug, and then they postpone the surgery because they feel good. And there's no reason why you can't continue monitoring them, because if it's a small tumor and there's no growth of the tumor and they're biochemically controlled, your outcome will be the same. In fact, Dr. Baldelli in Italy many years ago did an uncontrolled study, but a very nice study, showing that the long-term outcome for the small tumors who were controlled on somatostatin was identical to the long-term outcome if they had surgery for the small tumor. So although the studies were uncontrolled and it's not in the label, you can offer a patient a reasoned approach to understanding the risks and the benefits of primary medical treatment versus going straight for surgery, or postponing surgery while they have primary medical treatment to put them in better shape for the surgeon. However, there's one caveat. We don't really know that preoperative somatostatin will enhance the subsequent surgical success. There were some early studies from Scandinavia and from China showing there's marginal benefit after 6 months if you look at the outcome of surgery if the patient had received preoperative somatostatin. However, the long-term clinical outcomes are not definitively shown to encourage that approach to help the surgeon. Although if you shrink the tumor, you clearly help the surgeon, there's no strong prospective control evidence that you'll actually improve long-term outcomes. Thank you for the question. It's a very common question which patients will encounter you with.
There is a question from an audience. Is there any association between cabergoline and radioresistance of tumors?
You know, I don't know the answer, because in the literature, there was a mild implication about bromocriptine many, many years ago. I understand that that's not the case with cabergoline. And the reason that I can't give you a definitive answer is we don't use cabergoline. So our surgeons don't see that. So we don't have experience. We find that we only use cabergoline very successfully for prolactinomas. We don't use cabergoline for acromegaly because it doesn't work. And you need very high doses. Patients get nauseous. And most importantly, when you get into the high doses, like a milligram a day, which is very high, but which you may need to suppress IGF-1, you run the risk of valvular disease, floppy valves. So I can't answer that question because we just don't have experience, and our surgeons just don't see the patients after cabergoline for acromegaly. They do see the patients, the resistant patients after cabergoline, the very few, as Dr. Corbodes pointed out earlier, very, very few patients with prolactinomas go to surgery. And in those patients, the very few who are resistant to cabergoline, the surgeons don't report a problem with those who have been on cabergoline. The original 30, 40 years ago concern with bromocriptine was that it caused fibrosis and would impair surgical access and surgical agility. That has not been shown definitively in any controlled fashion for cabergoline.
What is your approach to mixed tumors like lactotropinomas or a stem cell tumor which presents with GH excess in adolescents, especially?
There is no evidence. There was a lot of thought, but no evidence that the mixed tumors are more responsive to cabergoline. So if your patient is the rare one who is responding to cabergoline, it'll make no difference whether or not they are secreting hyperprolactinemia or not. In terms of mammosomatotroph or stem cell, acidophilic stem cell tumors or mammosomatotroph tumors, those are usually more aggressive. Those are aggressive tumors. They're big tumors. They're often associated with not often because it's rare, but they're associated with gigantism. Those patients I would operate on early to try and decompress as much as possible, because the acidophilic stem cell adenomas are aggressive and morphologically invasive tumors.
Yeah, how do they respond to somatostatin ligand therapy?
They respond well. We've reported several patients who've responded well to the somatostatin.
The next question is cost of oral formulation vis-a-vis injectable. In your setup, how costly is this oral formulation of? For us, it's a very important question. We as you know, the insurance situation in the USA is highly unique in that the government doesn't pay for medication unless you fall into certain social categories where government support is available for elderly people or for people who are on government-supported health plans. And so it's very important that cost be taken into account. And the cost of the oral somatostatin is equivalent to the dosage of lanreotide. It's not higher. My co-chairs, Dr. Nihal Thomas, any questions, comments from your expertise? Dr. Nihal, are you there?
Yeah, thank you, Dr. Murli. I have no further questions. Thanks so much.
No, there are some more questions in the chat box. I think Dr. J.J. Mukherjee, on the role of external beam radiotherapy post-op in people with residual active disease who cannot afford expensive medical treatment. This is a very common scenario in India. We can't afford any of these treatments which are personalized, and many patients may have to live with residual disease. So how do you look at this Indian scenario, what we can offer to them?
Yeah, that's a very important question. And not only for India, it's an important question for North America as well in terms of health insurance and coverage for therapies. I'm not sure it's a relevant question to countries with central government payment for drugs. So for North America, it's the same problem as in India. And for those patients, clearly radiotherapy, in my mind, is far more beneficial than repeat surgery. The only concern with radiotherapy is try and make it focused, because as you know, there is data from the UK, especially from the Midlands acromegaly study, that unfocused radiotherapy, the conventional radiotherapy, is associated with an increased mortality from stroke. But with that one caveat, focused radiotherapy is a good approach. It's far more effective and safe than repeat surgery in terms of side effects. My only caution would be, please follow these patients for the rest of their lives, because they will develop pituitary failure, and they may require thyroid hormone replacement, and sometimes steroid hormone replacement as well. So especially 10 years out, please follow these patients for development of pituitary failure. But it's clearly a focused radiosurgery is a very, very effective approach after surgery. I wouldn't use it prophylactically, but if the disease recurs or persists.
One question on how to manage patients with elevated GH but normal IGF-1.
Oh, it's usually the opposite. The question is usually the opposite: normal GH and elevated IGF-1. And the answer to that question is easy. Just repeat the IGF-1 and it's a different assay. It'll come back normal. In terms of elevated growth hormone and normal IGF-1, I would do an oral glucose suppression test, OGTT, and look for suppression of growth hormone. And most of those patients, you will find that growth hormone will suppress to less than 1 within 2 hours of a glucose load. Remember that normal growth hormone secretion is very erratic and sporadic. You can get peaks up to 20 or even 30 nanograms per ml if you draw the growth hormone at the inappropriate time. Especially if the patient is fasting, there may be very high ambient normal growth hormone peaks. So either if you have the resources, measure, if you're going to use growth hormone as your marker, measure growth hormone over 2 hours, say three, 4 times, and get a mean, or do the glucose load. And the glucose load is quite easy, and you'll find that most of those patients with so-called spikes of growth hormone and normal IGF-1s, their growth hormones will suppress after a glucose load.
In this context, one of the delegates is asking, if with uncontrolled diabetes, how to investigate for suspected acromegaly. Does your GH suppression with glucose alter in uncontrolled diabetes?
Yeah, if it's an uncontrolled diabetic, first of all, try to control the blood sugar and then measure the IGF-1. But if there's a tumor present and the IGF-1 is marginally elevated, and you have the clinical phenotype of acromegaly, you don't need a growth hormone measurement in a patient where there's a problem of interpretation because of the diabetes. What I will add, and I didn't have time to talk about it, is that pegvisomant in those patients is more effective than octreotide in reversing the elevated blood sugar levels. There is good data that pegvisomant is more beneficial than a somatostatin receptor ligand in the presence of diabetes and acromegaly.
We have a few other questions.
Several more questions coming up. Can we ask the organizers? Do the organizers give us more time?
If Dr. Melmed has time, please go ahead.
Certainly, I have time with pleasure.
Right. So can you put this question?
I think you read the rest of the question.
Yeah. So how would you manage a pregnant lady with acromegaly?
Okay, so I'm pretty conservative when it comes to pregnancy. I try and protect the mother beforehand and say, don't get pregnant. I'm really conservative, and especially if they have a residual mass, I explain to the patient, you have a risk that your mass is going to expand, that you may hemorrhage. It's a low risk. But if I'm your doctor and my responsibility is to your health, my advice is use mechanical contraception. I don't encourage pregnancy. If the patient wants pregnancy, we make sure they're controlled. We make sure there's no residual tumor. Let them get pregnant, and at that point, we stop somatostatin receptor ligands, although because it's not on the label, it's not approved. Although there are reports that it is safe throughout pregnancy. So if your patient wants pregnancy and they do have a mass and their growth hormone or the IGF-1 is not controlled, and you do decide to continue somatostatin analog, the case reports are that it's safe. However, be concerned about fetal hypothyroidism. because somatostatin crosses the placenta, and as soon as the baby is born, you should check their T4 levels right away. And if needed, even transiently, give them T4 replacement. So most of us would prefer not to give a somatostatin analog throughout pregnancy for that reason. And then, of course, if the tumor really blows up, expands during pregnancy, even if it's the second trimester, you can offer the patient surgery, transfemoral surgery during pregnancy. Remember, MRIs are safe during pregnancy, so you can follow the patient with serial MRIs if you need to. But generally speaking, if there's a residual mass or there's a macroadenoma, I discourage pregnancy. But again, that's my personal conservative approach.
And we have a question from Dr. J.J. Mukherjee that's about post-operative follow-up.
Post-operative what? You're cutting out, sorry.
Post-operative follow-up. How do you assess cure or control? You use IGF-1, GH random, or glucose-suppressed GH? Or combination of all?
Okay, so we currently following long-term IGF-1. So we do IGF-1 depending on the frequency of visits, every 4 months, every 6 months, even every year if they're well controlled. And we don't do glucose loading at all. There's some very nice papers now though showing that you can actually predict that by doing a 24-hour post-operative growth hormone random, 8 a.m. random GH, 24 hours after surgery. If that is totally suppressed, you can be pretty sure, at least based on 2 studies, that there will be long-term control in over 95% of those patients, the pretty strong predictive power. But we don't do OGTTs, and we usually don't measure growth hormones in the long term.
Treatment approach in AIP patients.
Well, you have the world expert, Dr. Korbonitz, on the line, and she's the one to answer that. The patients with the AIP mutations are usually those who are in families, they're younger, they have bigger tumors, some of them are giants. So it is a whole different focus of attention. And then, of course, you need the genetic screening of the families. But they usually would have aggressive, larger tumors. If Dr. Korbonitz is still on the line, I can see her name here. Why don't we let her, she's the expert, respond to that question.
Thank you so much. Yes, I'm happy to reply. So the typical AIP patient would be a childhood onset acromegaly with a large tumor. And this is how the disease often presents. And these patients need surgery. That's first and foremost, because even if the tumor is very big, it's very good to reduce the bulk of the tumor, even if you know before surgery that you will not be able to cure the patient. As I mentioned actually earlier, answering one question, they are also prone to apoplexy. So that's another reason to reduce the tumor burden. And most of the cases don't respond very well to first generation somatostatin receptor ligands. For pasireotide, I mean, as is usual in the literature, the positive cases where they responded well, they are published. And those cases when it was given to the person and it wasn't successful, it wasn't published. So in my experience, this is the case. In some patients, you get a response, and in other patients, you don't. But you often have, when it's a very severe case, it's often not much to lose. So you can still give them pasireotide and see what happens. And they obviously respond beautifully to pegvisomant, because everybody responds to pegvisomant if you give the right dose. It's purely a dose issue. We found, and we have kind of patients now in their 60s and 70s, that they respond really well to radiotherapy. And these patients who are now at that age were treated with radiotherapy many years ago, and they reached control of the growth hormone secretion. So they are more responsive to radiotherapy than, for example, some prolactinoma patients. So radiotherapy is a good treatment for these patients with all the biases and negative effects, especially if you give radiotherapy to a young person. It's really not good. But in terms, just purely looking at the tumor control, it does work. So that's kind of a short summary. And that's what we do. Just a little addition that not all the patients, now that we screen the families, not all the patients have the big tumor, very aggressive. We see now patients prospectively diagnosed. Some of them just have an ordinary type of acromegaly, which means that based on photos and everything, you see that it was growing for 15 years and they only, let's say, 2 centimeters, although the person is taller than they should be. So you know that it's started from before they fused their bones. And we also have some family members with small lesions, which can make some hormones, but in many cases, they don't make any hormones. They are well visible on the MRI, but they don't make anything. So they are practically incidentalomas. And we don't know if these are actually related to the AIP gene, whether they have a loss of heterozygosity of the gene and they develop due to the germline mutation, or they are true incidentalomas like anybody can have. And because these patients are never operated, we don't have the tissue, so we can't look at it.
Marta, can I just ask, is there any role of temozolomide in these large tumors with AIP positive?
Yeah, so is the only case which I'm aware is treated with temozolomide is actually a case from India, which was a very young boy at the age of 4 suffered apoplexy and tumor growth, and really was very difficult to control. So in this patient, we've given temozolomide, but no, I'm not aware of any other patients. No, none of the UK patients were on temozolomide or ever been. And to be honest, the having pegvisomant and having radiotherapy, I think you can control most of those. This patient in India didn't have access easily to pegvisomant, and she would have needed a huge dose of pegvisomant, at such a young age. I mean, another interesting issue which I actually would like to ask Shlomo is, if you see a giant and you know that the surgery will not cure, and especially if it's a girl, will you get in the pegvisomant just quickly to save height gain, to avoid that child to grow very tall? Because even if you start all the treatment, it will take you, a year and a half, 2 years by the time you can control the IGF-1, and the person with delayed bone age can grow 15-20 centimeters during those 2 years while you are kind of trying your best. So is there a point to come in with a pegvisomant straight away to normalize the IGF-1? And then do the surgery and do all the other things what you can do, just because of the height gain, which you cannot return. You cannot make somebody shorter.
Right. So that's unfortunately that's a rare encounter, because those patients are so rare. We actually have published one case, so and another giant which we haven't published, who have received pegvisomant successfully, and I think Ariel Barkan has also published a case where a giant was given pegvisomant. So I think that's a very rational and intuitive approach. But because we're never going to have a controlled population, it's going to be very difficult to rigorously answer the question, and those will have to be one-offs to try. But at least in those 3 cases that I'm aware of, pegvisomant is extremely successful and intuitive.
Yeah, so what I'm saying is that to give it early, because usually pegvisomant is you give it at the end when you tried everything else. But because here there's something which you cannot turn back, you
unless you have surgery, immediately, and it's rare to have surgery.
Yeah.
I think we had a wonderful session with all the greats in the field, and I'm being prompted by the organizers that we have overshot our time limit by quite a lot. So it's my pleasant duty to thank all of our speakers for their wonderful deliberation, and all of you who have joined in and put in those excellent interactive questions. And I hope we have learned a lot together, and we do hope to see you all again tomorrow. So with this, I hand over back to Lisa.
Well, thank you, speakers. Thank you, Professor Melmed, Professor Korbonitz, and the chairpersons. It was a really wonderful session, and we are grateful and really thrilled to have been part of this. Thank you once again.
Thank you. It was
Thank you. Thanks for having us. Thank you so much.